Give me one more night. Just give me one more night. Give me one more night. You know I can't wait forever. I've been trying oh so long. Give me one more time. Let you know. Just give me one. Let you know how I feel. Give me one more night. You know I can't wait. So if I stumble or if I fall, would you help me back so I can make you see? Please, will you give me just one more night? Just give me one more night. Give me one more night, you know, can't wait forever. Give me one more night. Just give me one more night. Give me one more night. Cause I can't wait for one more night. Like a river to the sea, I will always be with you. If you sail away, I will follow you. So give me one more night. Just give me one more night. Give me one more night, you know, can't wait to say. I know there'll never be a time you'll never feel the same. And I know it's only worth it. One more night, you know. If you change your mind, you know I'll be here, and maybe we both can learn. I'll give me just one more night. Just give me one more night. Give me one more night. Cause I can't wait forever. Give me one more night. Just give me one more night. Cause I can't wait forever.
I know just how to whisper, and I know just how to cry. I know just where to find the answers, and I know just how to lie. I know just how to fake it, and I know just how to scheme. I know just when to face the truth, and then I know just when to breathe. And I know just where to touch you, and I know just what to prove. I know when to pull you closer, and I know when to let you loose. And I know that I
Para peserta sekalian, sesi seterusnya adalah sesi ceramah oleh Mr. Lim Wei Shung, pakar perubatan ENT. Topik beliau pada hari ini adalah Operative Aspects and Complications of Tracheostomy in Adults. Dipersilakan.
Okay, good morning, everyone, and welcome back to our tracheostomy course. I hope you enjoyed our musical playlist, specially curated for you by Dr. Izzat. Before I begin, just want to thank everyone again for logging in and supporting our kursus, whether you're on Zoom or YouTube. And for tomorrow, participants who are coming for the hands-on. So we look forward to seeing you, and then we can go through the hands-on practical session. So now just let me share my slides. Okay, so I'll be talking about the operative aspects and complications in adult tracheostomy. Just now, earlier we went through basic anatomy and the types of tube. So before we talk about care, trachea care, we just a quick run through on the procedure itself. Okay. It's just some definitions. Tracheostomy is the surgical formation of an opening into the trachea. So the opening is called a stoma. It can be temporary, permanent, and it's done as an elective or emergency. And the tube is the artificial airway that is inserted into the opening during the tracheostomy procedure. So very simple definitions. Just a bit of history. The first tracheostomy done was way back in 1546. It was an Italian physician, and his indication for the tracheostomy was a patient who had a tonsillar obstruction, and with the tracheostomy, he was able to breathe. The first pediatric tracheostomy done in 1620, and this was done in a boy who swallowed a bag of gold. So it was lodged in the esophagus and obstructed his trachea. So over the years, over the decades, it became more popular for airway protection. And up until today, in the 1900s, it was when Chevalier Jackson advocated the low tracheostomy incision, which is what we are doing up until today. So when we talk about any surgery, there's always three parts to it. You have the preoperative part, and then you have the procedure itself, and then post-operative care, and that's where the trachea care comes in. To me, I feel the preoperative planning, this is like the most important part of the entire thing, where you need to know your indications for your tracheostomy, not just tracheostomy, but for any surgery, and consent as well from the patient, and in this case, also from the family members as well. So we know that your tracheostomy can be done, as an elective or as in an emergency setting. And it's always essential to obtain adequate consent before you do the procedure. And we generally counsel patients and sometimes even family members as well. For example, patients who are ventilated in ICU, they're not awake and all that. So you need consent from family members. And this is very important because they need to understand the rationale behind the indication for the tracheostomy. If a patient wakes up and suddenly there's a hole in the tube in your neck, it can be quite traumatizing. So they need to understand that from the beginning. Your patient and your family members, they need to understand the lack of vocalization, difficulty in communication, and what to expect with a tracheostomy tube in their neck. And they should also be informed about your various complications that may arise. And this is something which is very important. That we should also let them know that sometimes, as much as we prefer this tracheostomy to be a temporary solution, it can always end up as a permanent solution, depending what happens after the surgery. The next thing you need to do is to properly assess this patient. You need to do a proper physical examination. Look at the patient's neck. Is the patient has a very thin neck? Is it a thick neck? Is it a short neck? How much can we extend the neck? The position of the trachea, is it palpable? And sometimes we also look at the size of the ETT tube that the patient is currently intubated with. This is for patients that are intubated in ICU. If there is radiological imaging, that would be good as well. your CT scans, and again, depending what the patient is having, any cervical fractures, that will determine how much you can extend the neck, or can you even extend the neck at all. Or patient with head and neck tumors, most commonly, thyroid tumors. So these are things, if you have them, it's very good to look through before you do the surgery. And then your usual your blood investigations, talk about your full blood count, you look at your Hb, your hemoglobin, your platelets, coagulation parameters. And another thing is a medication history, and anticoagulants is always something that we look at. Commonly used aspirin, warfarin, Plavix, heparin. So these are the anticoagulants that you see patients on. Now, as far as I'm aware, there are no absolute or strict guidelines with regards to optimal blood investigations, management of anticoagulants prior to surgery. Of course, before doing surgery, you want everything to be perfect. We want our counts to be, our Hb, our platelets to be normal. I mean, we try as much as we can, but it also really depends from patient to patient. And sometimes, you are unable to achieve this kind of optimal parameters, and the patient will need a tracheostomy anyway. So again, a lot of it is also on a case-to-case basis, and then depending how urgent the tracheostomy is also needed. But just a quick run through the anticoagulation. Management of patients on anticoagulation is usually a challenge. And because your interruption of therapy can increase the risk of your thrombotic events after surgery. But if you do not interrupt your anticoagulation therapy, you can also increase the risk of bleeding during surgery, ranging from minor to uncontrolled bleeding. And when you have a lot of bleeding in an airway case, it can be quite complicated, or it can end up complicated. So your common anticoagulants, your aspirin, your Plavix, warfarin, heparin. Okay. So aspirin, usually your most commonly prescribed antiplatelet drug, has a short half-life of 3 to 6 hours. Irreversible effects can however last the complete lifetime of your platelet, about 8 to 9 days. Whereas for clopidogrel or Plavix, these are prodrugs which the active metabolites irreversibly affect your platelet function. So sometimes it's also recommended to interrupt these drugs about 5 to 7 days before non-cardiac elective surgery. And so you'll find a lot of suggestions and guidelines online, that each may have their own, suggestions on when to stop and how to stop. Okay. But again, like I said, there's no fixed thing. Sometimes, you need to do a trachea even if the Hb is low, or if your platelets are low, so you can always stabilize these patients pre-op or even during the surgery itself, if you have to do it anyway. So so let's just quickly go through the tracheostomy steps. First things first, positioning of the patient. That is very important, because the way you position your patient is going to affect your surgery or while you're doing the tracheostomy. We always place the neck in an extended position, and you need to identify your surgical landmarks, your sternal notch, your cricoid cartilage, your thyroid cartilage. So because by identifying these surgical sites, then you would know roughly or exactly where to start looking for the trachea. And once you're unable, and at the same time, let's say if you get into trouble or you find some difficulty intraoperatively, these are the same landmarks that you use to find your way back. You can give some local anesthetic, infiltrate after you identify your landmarks. And your incision is usually a transverse line, halfway between the lower border of your cricoid cartilage and your suprasternal notch. Because when you extend your neck, you pull the trachea up, and usually it is within this area you can find your second, third, fourth trachea ring. So your incision again is made through the skin, dissection through your subcutaneous tissues. It is always advisable to go layer by layer, especially in the neck that has not been operated on before. So if you rush through, you miss your planes, you miss your layers, you may end up not knowing where you are. So again, identify your strap muscles, and we generally tend to divide this in the midline because it is not so vascular in the midline. Care is taken not to damage your anterior jugular veins, which is usually slightly more lateral, or sometimes you can also cross the midline. So in cases like this, you just need to ligate it. Once you have done that, you need to identify your thyroid isthmus. So this again varies from patient to patient. Some patients have a bigger isthmus, some patients have a smaller isthmus. Some patient, the whole thyroid gland is huge and it's blocking your entire trachea. So this is an important step to look for. That's why you need to dissect slowly and take your time. You should identify any large vessels at the inferior border of the isthmus. Again, this is depending on how you want to do it. Some people retract the isthmus superiorly, some retract it inferiorly. And sometimes if it's too big, they can even split the isthmus apart to expose the entire length of your trachea. So we expose the trachea by blunt dissection. If you have an assistant, that will be much easier to help you with the retraction. Otherwise, you can use retractors so you can visualize the entire length. Next, you do a tracheostomy window, the third or fourth tracheal ring. Sometimes if it's difficult, you can go up to your second ring. So there are many ways to do it. Some just make a horizontal incision. Some actually create a window. So it all depends on the surgeon, but the principle is the same. You just want to create an opening into the trachea. So once you've made your incision or made your window, you can see your ETT tube through the window in the trachea. So this is when you let your NS colleagues know that you need them to pull the tube so that you can put your tube inside. Okay. Now, before you put the tube, you always need to check because these are ventilated patients. Usually you would use a cuff tracheostomy tube. So make sure the balloon is functioning, because if it's not and it's torn, and you can't inflate the balloon, then there will be problems with ventilating the patient. You take out the tube and you put in a new one again, a lot of unnecessary extra steps. So make sure your tracheostomy tube is functioning, your balloon is functioning, so that you don't have any of these issues. And then you can put the insertion of your tracheostomy tube. Okay. So tomorrow during your practical sessions, there will be a station on tracheostomy tube change, and then we will show you how this can be done, and you can even try it yourself. Okay. So finally, you suture the flange of your tracheostomy tube to the skin, to the neck. Make sure it's in position. This is when you first do the tracheostomy, this is actually a very critical part. You need someone to hold the tube, get dislodged, because your tract is not formed. You just made an incision. So you need to make sure that it's not too tight, but not too loose as well, so that it doesn't get dislodged. And this is just a picture. Once the tube is in, from the trachea itself, we put a scope in, and you can see the tube coming in and the balloon that is inflated around it. So that's how it looks like inside. So just some caveats and some tips or tricks, for surgeons who are doing tracheostomy. Usually an extra assistant is always usually very useful to help in retraction. It is obligatory to have adequate lighting. You need to make sure that you can see what you're doing, because you don't want to be dissecting in places you shouldn't be dissecting. Your surgeon should not rush, and all the necessary time is taken to identify your anatomy systematically. So this is that you don't lose your way while you're trying to find the airway. Now, a large neck always presents a challenging case for tracheostomy incision, even short necks or very thick necks, so there's no harm in maximizing the exposure by making a generous incision. If you can get extra assistance as well to retract for you, this will make it much easier for you. Now, your incisions can be wrongly placed. You can be too high, too low, and when this happens, it can be difficult to identify your key anatomical structures, and you can make your proper placement of your tracheostomy window or your incision challenging, which is why you need to right from the start, you need to really identify your anatomical landmarks. You need to position the patient properly, so you reduce the risk of this happening. So your thoracic isthmus should always be dealt with and ensured that there is no bleeding afterwards as well. So your tracheotomy can be performed in a number of ways. This is when you're creating that opening into the trachea. You know, there you've got horizontal incisions, vertical incisions, various shapes of window excisions, you know, to put the tube in. But with all this, there comes some risk. You know, if it's done too high, then there's a significant risk of subglottic stenosis. If it's too low, it will make your tracheostomy tube change very difficult, and you are also going to be dissecting under the sternum, you know, and there's a lot of big vessels there, so you increase risk of bleeding as well. If it's too large, then there can be a significant leak, and there's a higher risk of tube dislodgement. But if it's too small, then it'll be difficult for you to push your tube in, and you sometimes, if you can also end up, you know, creating a false track because you can't put the tube into the tracheal lumen. So these are just some of the things, you know, to keep in mind while you're doing your tracheostomy. So your correct insertion technique is very important, because if you don't do it the right way and you rush and you try and force your tube in, you can easily create a false passage tract, and you end up with airway obstruction either during the procedure or the post-operative period. In the post-operative period, it would be worthwhile to do the first tracheostomy tube change using a guide wire. So again, during the session, you know, we will show you how to do this. This is because it takes about at least, you know, 5 to 10 days for your 5 to 7 days within a week for your tract to form nicely. As long as your tract is not formed nicely, there's always a risk of your tube being dislodged or you get a false tract. So there's just some of the tracheostomy complications that can happen. It can happen anytime during the surgery, after the surgery, and after surgery it can occur, you know, immediately, and then we also have late complications, you know, later on. So intraoperatively, usually complications, they happen, you know, is when the surgeon deviates from working in the midline. So one thing the surgeon can do is, whenever you are dissecting and you are not sure, especially in very short, thick necks, you know, you always keep palpating for the trachea, so you don't keep, you know, so you don't end up dissecting where you're not supposed to be dissecting, and you can keep yourself in the midline. Commonly, bleeding, hemorrhage, you know, from your anterior jugular veins, like I said, you know, usually they run lateral, but sometimes they also run across the anterior part of your trachea. Your thoracic isthmus and your superior mediastinal vessels. This is when you start dissecting too low and you're going into the mediastinum. You've got a lot of vessels there, and these vessels, when they start to bleed, or it can be very difficult to stop the bleeding. Pneumothorax can also happen. This is from direct injury to your pleura, lung apex, or low tracheostomy. Again, when the surgeon is dissecting in an area that you're not supposed to be dissecting, but also commonly, you know, a higher risk, especially when you're doing tracheostomy under LA, in a patient that already has some form of airway obstruction. You know, patient is really having difficulty breathing, and you're trying to dissect. So there's always a risk of hitting the pleura. Surgical trauma to adjacent structures, your carotid sheath, esophagus, recurrent adrenals. These are not common, but it can happen. Again, if you don't know where you are dissecting and you are just blindly trying to find your way through, these are all structures that are just next to the trachea, and this injury to these structures can happen. And then you can also get surgical emphysema, usually when there's a tight closure of your tracheal wound, or when you have created too large a window, so you get some air leak. And when you suture your wound too tight, you know, air gets trapped, and then you get some surgical emphysema. Or if it's a false passage or tract, you know, you think you're in the trachea, but you're not, and the ventilation is going on, so air is being pumped into your subcutaneous tissues. Okay, post-operatively, these are the two main complications that we come across It is either tube displacement or dislodgement, and also tube obstruction. And these are the two reasons, which is exactly why we are doing this tracheostomy course, because these are the most common complications, and it can cause a lot of morbidity and mortality. So this is actually the most important part of your trachea course. Your tube displacement and dislodgement most commonly occur within the first few days post-operatively. It can even occur immediately after the surgery, when you're transferring patients from the OT table to the bed, push to ICU. These are all movements of the patient. And because it's a very fresh track, it's not formed yet. So when your movement of your patient is too careless, what can happen is your tube dislodgement, or if you don't tie the tracheostomy tube around the neck, it's too loose, it's not tight enough, so this can happen. Tube obstruction is a very avoidable complication, but if you're not careful, it can be potentially fatal. The reason you're doing the tracheostomy is you want to protect the airway, but if you don't take care of what you are trying to protect, they may end up dying from it instead. So this is what we see a lot in wards. The most common cause is accumulation of mucus crusting in your tracheostomy tube or your tracheal lumen. Especially the first few days, your first week, there's bound to be a lot of secretions coming out through the tracheostomy tube. So your trachea care the first week is actually the most important. Okay, all the best to that patient, that Kot Pelangi. So again, most common cause, accumulation of mucus crusting in your tracheostomy tube or your tracheal lumen. And this is because no one is doing the suctioning. So your secretions get stuck in your tube, it blocks the tube, and it blocks the only airway for the patient, and which is why this is potentially fatal. Another thing that can happen is formation of granulation tissue. This can happen if it's a fenestrated tube. It can happen through that fenestration, or it can also happen distal to the tracheostomy tube within the lumen itself. And again, this is because of the way you suction, and these are things that we will show you tomorrow. Tracheal necrosis is another complication that can happen, and usually this is because of overinflated cuff pressure. We inflate the balloon too much, and it presses on your tracheal wall, reduces your capillary flow, and your mucosa will start to necrose. So it can present as an ulcer on the wall of your mid or lower cervical trachea. So your tracheoesophageal fistula is another one that can another complication that can happen. It can also happen, during your tracheal incision when you put your scalpel blade in and you cut too deep. So these patients present with aspiration, chemical pneumonitis. So this is a picture. You can see your fistula, your posterior wall of your trachea going into your esophagus. So you got small ones here, and you got a very big one here. Huge fistula. Okay, now your later complications, usually subglottic tracheal stenosis. This can happen because of your injury to your cricoid cartilage, your upper tracheal rings, scar contracture, or granulation tissue which converts into a scar. Okay, very commonly occurs at the site of your trachea. It can be the tip or even above the tracheostomy tracheostomy incision. So these are very difficult complications to manage, may require multiple surgeries, and sometimes patients even end up with a permanent tracheostomy. The other complications would be your persistent tracheocutaneous fistula, and again, difficult decannulation, where you're unable to decannulate the patient. Usually there's always a persistent obstruction above the tracheostomy. Patients still have vocal cord palsy, or there's a subglottic stenosis, which is why you can't decannulate. And a very important thing to note is that you need to you need to do an endoscopic assessment of your upper and lower airway before you decannulate the tube. You need to know what's going on in your lumen before you just simply pull the tube out, the hole closes, and then patient comes in again with another airway obstruction later on. So these are just pictures, showing some subglottic stenosis. You can see the hole is very small, and if you don't have a look through, you wouldn't know what is going on before you decannulate the patient. Okay, so these are my references. Thank you.
Terima kasih diucapkan kepada Mr. Lim atas sesi perkongsian yang bermanfaat tadi. Sesi terusnya adalah ceramah daripada Mr. Burhanuddin Salim, pakar perubatan ENT Hpj, dan topik ceramah beliau ialah Tracheostomy Care in Adults. Persilakan.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to everyone. Again, thank you for attending this online course. So I understand from the Urstia, our participants today online are half doctors and half paramedics lah. Okay, and my topic today is tracheostomy care in adults. Just as a side note, there will be another talk. I'll be giving another talk this afternoon in tracheostomy care for pediatric patients. So memandangkan kita ada paramedic juga, and I think most of our tracheostomy care do involve paramedics particularly. So I'll be speaking both in BM and as well as English. All right, okay. So by this time, I think everyone is almost familiar with this diagram. Okay, tracheostomy, as you know, is the insertion of this tube through the neck into the trachea lah. Alright, you can see trachea kat depan tu, belakang is your saluran makanan, esophagus, right, and this tube coming out. So I think Mr. Dim gave us a very comprehensive review of complications that can occur. So what's important in this topic is those complications that occur post-operatively. All right, post-operative can be immediate post-op and can be early, can also be late. Our job as healthcare professionals, paramedics, doctors in the hospital setting is to educate and actually good care for post-tracheostomy care to avoid these complications along this period of time. Okay. So just as a context today, we'll be talking about tracheostomy care in adults, and we'll be focusing on immediate post-op and early care. So I won't be talking much about home care or later care, because most of it is done in clinic under the ENT follow-up. All right. So immediately post-op, there are a few things, a few considerations, and which we have to focus on. All right. So these are the things, and I'll be going through all this. Again, mainly tracheostomy care post-operatively is to avoid those complications that was mentioned earlier. All right, at least minimize it so that patient can benefit from the tracheostomy. All right. So first of all, we'll talk about airway patency. Now this has to be done frequently by everyone who is attending the patient. Doctors, housemen doing rounds, MOs from other teams, MOs in ICU, our nursing staff, especially during the nursing assessment. So how do you test for airway patency? So of course, if patient is ventilated, it's a different thing. Airway patency would be kalau ada problem, it will be detected by the ventilator. So this will be patient whom tracheostomy is done for without ventilation, those with cancer and other things for hair and neck procedures. So some patients after tracheostomy go straight to the ward instead of going to the ICU. Because some patients go out of tracheostomy without ventilation, so straight with trachea mask, okay, straight with on air, right? So in the ward, you have to the staff in the ward must know how to assess for airway patency. So how do you do that? Number one, basically you look for the air, not look, actually you feel or you hear for air blast. All right, the air blast can be heard or felt. So you can dengar bunyi daripada tracheostomy opening tu, kalau ada bunyi angin, you know it's patent. Or you put your finger, or your finger, or the back of your palm in front of the tracheostoma. If you can feel air blast, it's patent. If it's not, if you don't feel it or you don't hear it, then something wrong. You have to alert the doctors or the MOs. All right. Other thing we can do is cotton wisp test. Something that you put a piece of cotton in front of the tracheostoma, and just like something you put in front of the aircon, if there's air, if there's air air blast, you will see it move. Right. These things will go through tomorrow during practical sessions as well. Another thing we can use is a cold spatula, or in the case of ward setting, more commonly available is metal spoon or any metal things can put in front of the tracheostoma. If it mists, means there's air blast. All right. Now, patients able to speak. So this is something we get very often from nursing staff, from both in our hospital and at hospital across. So they will tell you, oh, patient is able to speak, doctor, very good, very happy. Patients so happy is able to speak. So in the context of early tracheostomy, this is not a good thing. Okay. Because Dr. Priya went through about just now about how the airflow moves around in the tracheostomy. So if the patient is able to speak, means the air is able to go out through the mouth, but unable to go out through the tracheostomy. So that means it's blocked, right? So it's not a good thing. So if the patient is able to speak post-operatively, immediate post-operatively, it's not a good thing, right? Usually this at this point, patient will be blue and also cyanose as well, all right? And of course, the other thing, the most important thing that you can do as paramedics, nursing especially, is the use of suction catheter as a way to assess the patency of the airway. All right, so we go through this next. So next topic will be suctioning. So suctioning is one of the most important procedures, nursing procedures for tracheostomy care, because it's therapeutic. It can clear secretions. It's also diagnostic. You can use it as a means of checking whether the stoma is patent or not. All right. At the same time, it can also be can cause problem to the patient, cause complications if not done properly, right? So when do you do suctioning for tracheostomy patients? Now, gone are the days where we do 4-hourly suctioning or 2-hourly suctioning. Okay, so we still say this in our nursing notes, di mana nurse akan cakap 4-hourly suctioning. So in between those 2 hours, when you pass through the patient, you hear the sound of, and then the patient coughing, you don't do suctioning because the order is 4-hourly suctioning. So not anymore. So I mean, there is a consensus statement by the Americans. They say it's not recommended to do predetermined time for suctioning anymore. So we should do suctioning whenever necessary, when the patient needs it. So when does the patient need suctioning? So these are the 3 main indications for tracheal suctioning. When there is secretions. Secretions can be seen or heard. Again, either you see patient, or you see the secretion coming up from the stoma, or you see gurgling, or you hear gurgling sounds from the patient. All right, that means the patient needs suctioning. And again, as I said, it's also a diagnostic tool. If you suspect airway obstruction, then you should start with tracheal suctioning first. All right. We'll go through this in our practical sessions, of course, the details of it, and of course before and after trachea change. So what do you use to suction the tracheostomy? So not just any suction tube. Okay, we have flexible suction tubes with different sizes. So healthcare staff should be able to estimate what size is adequate or appropriate for this patient's tracheostomy tube. All right. So what you should know before you do suctioning is you should know the size of the trachea, which means the inner diameter of the tracheostomy. All right. So not necessarily the size, because different products may have different sizing, but what's important is the inner diameter in millimeters. And how you can estimate the size of the appropriate suction tube is by these 2 formulas over here. Either you times 2, minus 2, or you divide 2 or times 3, because the reason is because the trachea size is mm and the flexible suction tube is in French gauge. Just a matter of conversion of unit, actually, right? And then the next point here is that multiple eye tube is preferred over single eye tube. What it means is that some tubes have only 1 hole at the end, and most tubes that we use actually have multiple holes. So this is better because we can divide the pressure, suction pressure, through the small tube, so that you don't have so much pressure, suctioning pressure on the mucosa of the trachea, if at all it's in contact with that. All right. So we know when to do, we know what to use. Now, how do you do suctioning, right? So in terms of there is a debate whether it should be aseptic or clean technique. So in the hospital setting, I think especially in the post-operative time, we are talking about the surgical wound. So anything surgical wound is of course aseptic. All right. So sterile technique is preferred in hospital setting. All right. Why do we need to do this? Because this wound is at this point is at risk of tracheitis, pneumonia, and fistula. So this has been shown to happen if you don't do aseptic technique. However, of course, later at home, when the patients do themselves or the carer, of course, they can use clean technique. All right, and this will be, of course, explained to them by the ENT team later on. Now, how much suction pressure do we need, or can be used for the patient? Does it matter? It does, because if you do too much, you can suck on the mucosal lining of the trachea. If at all you reach the you are in contact with the trachea, and this can cause damage. All right. So the sweet spot number will be about around 80 to 120 millimeter mercury. This is about 6 to 10 kilopascals. All right. So this is available, should be available in the suction pots, and you should take time to have a look at it before you commence on the suctioning. All right. Again, if you do it if the suction pressure is too much, it can cause mucosal damage, atelectasis, and catheter collapse. What this means that the suction is so high that the catheter tersedut dalam, so you cannot do suctioning. All right. Now, how long do you do suction for? Not more than 15 seconds, about 10 to 15 seconds. All right. So because what happens when you suction is you are actually causing the patient won't be able to breathe because you are depriving the patient of air for the duration of the suctioning. So if you do more than 15 seconds, you'll be causing apnea for 15 seconds. Right. So we don't do that. The patient can stop hypoxia. There are case reports of hypoxia induced, suction induced hypoxia in patients, especially those with high oxygen requirements and whatnot. All right. Again, just a side note, in the era of COVID, of course, patients with airborne precautions, COVID patients, we should use closed suctioning instead of open suctioning. Now, of course, everything is better with a video. So let's see a video of a tracheostomy suctioning. So these are the things that you should prepare before suctioning. Suction tube, suction. Okay, wash your hands. As I mentioned, aseptic technique. So let's get to the more important part. So connection of the suction tube to the fingertip and the suctioning tube. So this is a patient with tracheostomy. So you should tell the patient that what procedure you want to do. Okay, so ideally you should position the patient in a slightly extended position so that you can visualize the tracheostoma. All right. So it can be either you can put a roll, the towel roll, or just ask the patient to extend his head if he's able to follow instructions. All right. Some patients do have speaking valve. Mostly no lah in our setting. And inner cannula, those with long-term trachea, but in the post-operative period, they don't have that usually. So this is the most important bit. How deep you have to put the suctioning tube. So again, we can see this person is using a no-touch technique. Okay, if using sterile gloves, it's okay to touch it. Now, this is the most important bit. So suction tip ideally should not go any more than 0.5 to 1 centimeter beyond the tip of the tracheostoma. All right. Now this ideally should be measured prior to do suctioning, but with standard tracheostomy size 7, 7.5, 8, usually we talk about the length of sejengkal tangan, not more than that. Okay. Of course, I've seen nurses suctioning masuk sedalam boleh until patient cough violently, then nice, then you get the circulation out. So it's not really a good practice because you will cause mucosal damage to the trachea along this line. All right. So when you occlude the hole, right, you'll be causing the patient to be apnea. So maximum 10 to 15 seconds. Correct. Okay. Moving around the tube a little bit so that you get to suction all the secretions around the trachea. Okay. Then that's it. Right. So and then one thing to mention here is that the tube that you use to suction the trachea should be used only once, and if the tube has been used to suck the to suction oral cavity or nostril, should not be used in the in the tracheostomy, because the tracheostomy is a clean sterile area. All right. Next, let's talk about dressing. Okay, so usually patient from the operating theatre will have a dressing already in situ, and usually it's left until the ENT MO sees or reviews the next day or something like that. So this shouldn't happen and should be checked regularly. Okay, because evidence has shown that the dressing which are not checked properly can cause maceration to the skin, can cause infection and whatnot. All right. So this is dressing that we usually use in our hospital, which is a pre-cut keyhole dressing. Okay, of course, this can be done manually if you don't have pre-cut. And in the early post-operative period, you use acryflavine. Later on, you don't. If the wounds already nicely healed, you can use normal saline, or you can do without dressing as well. There are some commercially available dressing pads in pharmacies. These are usually hydrogel or soft materials, which is not irritant to the skin. All right. Now, at the same time, when you're doing dressing or checking the stoma, make sure you check for any signs of infection. So this has to be done as well when you do dressing. All right. So that's why lighting is very important when you do tracheostomy care as well. So these are the signs of infection. So you can see leakage, secretion, very wet. You smell bad. You can see redness around the tube. So this happens more in those with head and neck surgery at the same time, or with flaps. Okay. So these are signs of infection. You can see erythema around the tracheostoma, and here up here is a bit of a overkill, but yes, you do see maggots in the tracheostomy, especially patients going home without any proper care. All right. Next is a tracheostomy tie. So patients, of course, will come from OT with a tracheostomy tie. So is tracheostomy, how tight should it be? How loose should it be? All right. So the question is this the 3-finger correct, or the one with the 1-finger length correct? All right. So the answer is on the right side. So a tracheostomy tie, a proper tracheostomy tie, is appropriate when you are able to put only 1 finger between the tie and the skin. So this is very loose. So what happens when the tracheostomy tie is very loose? If the patient coughs, you can expel the trachea. 1. Number 2, the patient breathes in, breathes out, the trachea moves in and out. So this can cause friction to the trachea mucosa. This in turn will cause things like tracheitis, fistula, and all those that we mentioned earlier. All right. So it's very important for the nursing staff to check this. Okay. If you don't know how to change the tie, it's okay. You can inform the ENT MO. All right. And these are cotton ties that we use usually immediately post-op, and later on patient usually encouraged to use Velcro ties because they are more comfortable and less irritant to the skin. All right. Okay, cuff pressure. I think we Mr. Lee mentioned about excessive cuff pressure causing problems and irritation to the mucosa. All right. So this is the mechanism by which overinflated cuff can cause injury to the trachea mucosa. So when the cuff pressure is higher than the capillary pressure, you get ischemia causing hypoxia and necrosis. Necrosis, then when this thing dies, when the skin cartilage dies, there'll be a hole. So it depends whatever is anterior to the hole. If it's the skin. If there's a big vessel, it might actually erode into a vessel, causing a tracheoinnominate fistula, which can be fatal. These are the complications that can occur with overinflation of cuffs. Very, very serious. So what you can do is avoid or prevent it by regularly checking the cuff pressure. Of course, this is usually something that we do in the ICU setting. And the keyword here is that the cuff pressure should be maintained between 15 to 25 centimeter water. All right. Next, so this is something that we don't really do much to our trachea patient, all right? Especially in ICU and in the ward. Communication. So patient on trachea still want to communicate to you, and if you've taken out the ability to speak, as mentioned earlier, the patient won't be able to speak at all in the first few days or first few weeks, in fact, with the tracheostomy, especially those with the cuff. So how do you communicate with the patients, all right? So there is something we call a communication board, or alternative and augmentative communication strategies that we can use for patients, all right? And they can be divided into low technology or high technology communication methods, all right? So this is something that they use abroad, a communication board for patient. See, these are it can be very useful for the patient. They can just tick, I'm short of breath and I want to be suction. I'm thirsty, I want some water. You know, they don't have to they don't have to tell you, but they can just tick that, or they can point towards which area of the body which they think there's a problem. There's an itch at the feet, or you know, you feel like there's pain here or there, or the easiest probably is a writing board, okay, which you can use in the ward and should be offered to patient when the patient's in the ward. All right, and of course the easiest nowadays is just using handphone, right, typing. It's a quick video showing how communication is addressed in patients with post-tracheostomy patient. Just to show you how they use a few things. Okay, yeah, the patient will just point to the picture. So this is what we call a low technology communication strategies. It's a certain apps you can use. And these things you can get in Shopee for 20 ringgit, right? So so the summary is that even though these things look very simple, but they're actually they profoundly affect the patient, and because the patient has no voice post-op, so it's our job to actually offer them these kind of things, and they're very easy to get. In the ward, there's always paper and pen. In fact, you can do that. All right. So don't forget that when you see patients with tracheostomy. Now let's go to the early part of tracheostomy care. So once you've passed the immediate post-op, you know, you've avoided all the major complications immediate post-op. We talk about the early part of trachea. So after 1 week until discharge or something like that. All right. So one of the most important bits is the first tracheostomy change. All right. First tracheostomy change is usually done by the ENT team. All right. When you do it, for open tracheostomy, it's early, you can do as early as day 3, but usually we do it at day 5. You know, when the tract fully matures. Okay. For percutaneous tracheostomy, which is another technique of doing tracheostomy, usually we need to wait until day 10 for the tract to fully mature before we do a tracheostomy change. Again, must be done by experienced personnel. This usually means the ENT team in the hospital. However, what's important to say is that with assistance from all of you, all right, from the doctors in the ward, from the paramedics. So there's a lot you can do. There's a lot you can do to help this process. Okay, so the first thing is by knowing what we need to change the tracheostomy tubes. Okay, usually these are the things that we need to change tracheostomy tubes. These are all available in the ward. It will be very helpful if this can be prepared beforehand or during the procedure. Okay, replacement tubes will be brought by the ENT team. One same size, one smaller size usually. Flexible suction tube, again, by this time you would know what size is it, and you can prepare the correct size. Scissors, gloves, ties, lubricant, KY jelly, and ETT and ambu bag in case of unable to change trachea and the patient needs to be intubated. It is still quite a high-risk procedure, especially the first tracheostomy change. How do you do that? For those fortunate enough to join us tomorrow, we will be going through all the techniques we use to change tracheostomy. However, usually the technique that we use most often during the first tracheostomy change is a railroad technique, using either a bougie or more commonly a Ralph's tube. All right. So there's a video. I think a video will probably show better. So as you can see from this video, there's 2 persons attending to the patient during tracheostomy change. Yes, this is probably the best setting. You need 2 persons, because one needs to be the person holding the trachea, making sure it's inside all the time, and one person is the person who changes the tracheostomy. Now in this video, so you put the tube, the bougie or the railroad lah, so to say, inside. Take the trachea out. Make sure your other hand is holding the bougie inside too. Then you railroad. So this is a railroad thing. So you railroad the new tracheostomy using the tube. It's important so that you don't put the tracheostomy through a false track, which can occur during first tracheostomy change, because sometimes the mucosa is still a bit raw, a bit wet, so this can occur. All right, so everyone will have a chance to try this tomorrow, hopefully. So once, okay. So let's talk about humidification now. This is important because tracheostomy gets blocked because of secretion. Secretions, as we discussed, when you do tracheostomy, you bypass the normal humidification of the nose and the oral cavity. So there's no humidification of air. So the air goes straight into the trachea. So air is very dry. Secretion becomes dry. If secretion is not suctioned out, it becomes dry up. It becomes crusting. Crusting can cause blockage to the tube, and this can be quite bad for the patient because they get blocked tracheostomy tube, difficulty breathing. So one way we can avoid this is by using a humidification by means of either a humidified tube in the ventilation setting, or you can use HMEs, heat moisture exchangers. So these are available in the ICU like this, and in the ward, some wards have this, and actually nowadays it's very easy to get. You can get this on Shopee for 20 ringgit. Simple stuff, but really profound effect on the patient, because with this the patients can the secretion don't dry up very easily. And tomorrow we'll show you how to do suction through this. Okay, so some HMEs have oxygen tubes, oxygen ports, some without. So those with oxygen requirements still can use HMEs, and even those on air can also use HMEs. All right. Now, one thing to mention and to actually remind everyone is how to secure the tube every time you do procedure. As you can see from the video just now, as I said, there's one person in charge of holding the tracheostomy tube. All right. So it's always important to ensure tracheostomy flange is secured during nursing procedures, and this includes turning, this includes sponging, most importantly, transfer. Right? We see a lot of decantation or dislodged trachea during transfer from OT to ICU, or from ICU to the ward, from different bed to another bed. So again, this can be avoided by just making sure one person is holding the tracheostomy. All right, and dressing as well. So again, for any procedures, you might need 2 persons, and you have to consider that. So that's basically what was tracheostomy care during the immediate post-operative period and during the early period. Later at home, these are the things that we should consider later on. Usually out of hospital, usually in the outpatient setting. So caregiver instructions, which patients carer need to know how to conduct tracheostomy care. Number 2 is swallowing. Tracheostomy do affect swallowing. Something heavy there at the larynx so the larynx cannot elevate during swallowing. So there will be dysphagia, and do consider referring to the speech therapist for assessment if you feel the patient is having dysphagia. And again, communication, either using AACs, things like a communication board, or you can use a speaking valve. Of course, this has to be done with discussion with speech therapists, and we can refer them to outpatient for assessment for the above. All right. These are the things that you should mention to the caregivers. They should know these things, and they should be able to do suctioning, cleaning, maybe how to change tracheostomy tube, and home equipment. All right. Again, most of the talk today is mostly about hospital care. All right. Thank you very much.
Terima kasih diucapkan kepada Mr. Burhan atas sesi perkongsian tadi. Sesi seterusnya adalah ceramah daripada Mr. Azman bin Ali, pakar perubatan ENT Hospital Putrajaya, dan topik ceramah beliau ialah decannulation of tracheostomy tube in adults. Dipersilakan.
Are we good, Sinu? Okay. Thank you to the chairperson, Dr. Sinu. Assalamualaikum. Good afternoon to everyone. Welcome to the tracheostomy workshop. I hope everyone is still alert. It's almost lunch hour. I'm Azman. Today I'll be talking to you about life beyond the tracheostomy, or in medical terms, decannulation of the tracheostomy. So today I'll be focusing more on the adult tracheostomy decannulation and safe techniques for removal of the tracheostomy. This talk is pretty laid back, so don't have to take things too seriously, but just keep note of some very important points, because nowadays we live in an era, not just post-COVID era, but we live in a very medical legal era. So doing things in a safe way is important, because you have to be able to answer what choice of management you do. So decannulation of tracheostomy is a process of weaning off of the tracheal tube. It must be a planned procedure. There has to be documentation on the planning. And most importantly, there must be consensus amongst members of the treating team. So naturally, not all tracheostomy patients are purely a certain team's patient. It's most likely is a team management of the patient, usually complex patients or surgical patients, or even purely ENT patient, but with some role of the oncologist. So we have to keep track of the criteria, and the decision is very much an individually based decision. There's no worldwide acceptable consensus of how to wean off of a tracheostomy. But today, what I want for all the participants is to keep in mind important things to be considered when weaning off tracheostomy. So when we talk about weaning with a tracheostomy, some people may assume that the tube sits in the neck. So we basically bypass half of the airway resistance. But is it true? Is the airflow resistance really reduced? There's many studies that actually dispute this. Is it less work of breathing? When we look at the tube of tracheostomy, the largest we put nowadays is about 8 millimeter internal diameter. That's for male adult. Whereas the trachea can go up to 25 millimeter, or almost 3 times the size of a tracheostomy tube. And how about humidification and heating, the role of the nose in breathing? That is completely absent in trachea. And how about secretions? Why? When a patient has a tracheostomy, immediately they start coughing out large amount of secretion. The tube is a foreign body, and also the trachea gets cold air breathed into the trachea that causes a lot of changes in the trachea epithelium. And of course, the risk of infection, unfiltered breathing. So when we think about tracheostomy, we have to always keep in mind life beyond a tracheostomy. How to get this patient off all these disturbing factors for them. Okay, when we see a patient, nowadays we see a lot of patients with tracheostomy, whether it be in the clinic or even in the emergency department. But when we focus more on the clinic, we're talking about stable patients, patients coming in, walking in, or even on a wheelchair. They're not on oxygen. So when we see a patient, it's not just about thinking, okay, is this patient due for tracheostomy change? Do we send the patient back another 6 months for another change? We have to always ask ourselves, does this patient still need this trachea tube? Have you ever considered asking the patient, do you want this tube removed? In my experience, the patient will always say this is the biggest pain that they have, the tracheostomy tube. They don't worry about the Rouse tube or anything else. And if you ask them, Makcik nak cabut ke tube kat leher ni? Semestinya jawapannya adalah yes, yeah. Please get this tube out from me. So why? The patient wants their voice. They want to improve their appearance, you know. Patients are walking around with a mask on the face but breathing through a tracheostomy in the neck. So the mask is purely cosmetic in that sense. And it's uncomfortable. Imagine walking around with that tube when you don't need it. The swallowing, there will be some impairment, but this is variable. And of course, the patient wants to achieve independence. They would like to move on with their life and participate in all activities that any normal person can participate in. So the tracheostomized patient, when they're on room air, in their mind, they're thinking, man, I miss those days that I can sing, you know, even though you're not a good singer, but you can appreciate your own voice. I miss those days I can just swallow my food. I don't need to worry about something. I feel the tube when I'm swallowing. And most importantly, a tracheostomy patient cannot enjoy showers like any normal person. They have to protect that tube. So they are looking forward for the next shower, you know, and maybe they can even sing and eat in the shower together as well at the same time. So always think, how is this patient feeling? So is there a chance for us to take this tube out of the patient? So now we talk more about the technical aspects. When is it time to remove a tracheostomy tube? So the hope and expectation is always to remove it as soon as possible. Like I said, when we ask the patient, they'll say now. But we have to keep in mind that this tube is there for a purpose. So we have to make sure that the purpose is no longer necessary and it is safe to remove the tube. So some of the things that we can start thinking about is the initial indication of trachea. Is it resolved? Is the patient fully alert? You know, you don't talk about taking out tracheostomy tubes in patients who are not fully alert or poor GCS. Is the breathing good? Is there any oxygen requirement? Is there any need for any CPAP at night? And most importantly, is the patient able to cough out secretions? Is the patient able to swallow and feed? And how's the voice? Does the patient still have voice? Even though on tracheostomy, you can still have voice. I think we saw the earlier slide. So what is the danger? Removing a tracheostomy tube can be even more dangerous than performing the procedure itself. Procedure is performed in a controlled setting, whereas removing the tracheostomy tube is more variable. You don't see the trachea, you'll be taking it out. And the risk of failure can lead to the loss of airway, and of course, this can lead to very fatal complication. Any loss of airway is death within 6 minutes. You know, patient will become hypoxic, and it's very devastating. So decannulation must be always done in a safe and controlled manner. That is the best way. So the potential reasons that decannulation can fail, of course, airway pathology, which I'll show you some examples later. Poor cough, large amount of secretions, patient is aspirating on their own saliva or even food, ongoing lung infection, and also all these comorbidities we think about when we're planning for decannulation. Elderly patients with cardiac issues, neuromuscular issues. Some neuromuscular patients, they can talk, they can eat, they can do everything, but actually they don't have good breathing effort. So the tracheostomy helps in that sense to clear secretion as well. And then psychiatric patients and malnourished patients. So we have to clear all these things before we can even talk about decannulation. So some of the airway abnormalities that you can see here. So on the bottom left of my picture, we can see a trachea. This is below the tracheostomy tube, and next to it, this is what tracheomalacia looks like when the diameter, AP diameter looks like it's a compressed, but actually the trachea is a bit softer. So usually when you put a tracheostomy tube, the area where you cut the tracheal ring, it can become soft. So it's quite valuable to have a look at the trachea lower parts as well. This is a normal vocal cord. Or else in this picture here, I think this picture is similar to Mr. Lim's talk earlier. You can see a subglottic or even tracheal stenosis. Below here is a vocal fold in adducted, adduction. But unfortunately, this patient does not have abduction. So this is bilateral vocal cord paralysis in paramedian position and a slit-like airway. So taking out a tracheostomy in this patient will definitely lead to stridor. So this patient may be able to speak to you in a normal voice, but the moment you take out the tracheostomy, have difficulty breathing. And what this is a granulation tissue which has formed within the tracheal lumen, possibly near the site of previous tracheostomy incision site. So all these things need some sort of evaluation. So it's not just about plugging the tracheostomy tube and patient able to talk. You have to be able to at least safely see these conditions before you can safely talk about decannulating the patient. So in a nutshell, I revisit back all the previous slides just to give you 4 main criteria for tracheostomy decannulation. The first main one is a reversal of the medical condition which led to the tracheostomy being placed in the first place. So once the airway obstruction is resolved, let's say the patient had subglottic stenosis, you put a tracheostomy, you have reversed it. Okay, you can take it out. Let's say you put a tracheostomy for elective procedure, dental procedure. The dental team has completed everything. You can take out the tube. Why keep it longer? But if, let's say, the dental procedure or the ENT procedure or even the upper GI procedure is a procedure that involves the airway and is followed by adjuvant oncologic management, then of course you need to have some consensus, because this patient might need tracheostomy for upcoming treatment, whether it be any further radiotherapy, chemotherapy, and whatnot, which may lead to further airway compromise, edema, or even obstruction, increased secretions. All that, you should have some sort of discussion with the managing team, treating physicians with the patient before making a decision to take out. So reversal of medical condition is something that we can decide, but at the same time has to have a consensus. Let's say a thyroidectomy has been done, have taken out the thyroid, but what's coming up next? Is there RAI coming up next? Will this radio iodine ablation, will it cause any compromise in the airway? We may think not, but it'll be good to have conversations. Okay, so this number one I put in bold is probably the most important factor when you talk about criteria. And the others are more straightforward. Patent upper airway, as confirmed by ENT. Ability to cough and clear secretions, this can be, we can assess, and we can also check with the patient as well as his family members. And of course, we need to be sure that there is good ability to breathe, good lung reserve, and then there's no sign of infection, just a simple auscultation of the lungs. So these are simple criteria for adult tracheostomy decannulation. Okay, in the methods of decannulation, we can do it in either setting. During the same admission, the patient is admitted, done a tracheostomy procedure. For example, like I said earlier, some elective dental procedure. Want to take out the tracheostomy within the same admission? If both teams are confident in that, yeah, why not? Proceed with decannulation during the same admission. And also patients who are admitted for a prolonged period of time, especially patients in rehab facilities. These patients are already in the hospital. If part of the recovery involves removal of whatever factors necessitated the tracheostomy in the first place, then you can consider during the same hospital admission, yeah, let's move forward, save the patient time and trouble of going home for track 2, get it out. But this is not so common. The more common thing is we go slower, we send the patient home with okay, so more commonly, we will have patients referred to us in the outpatient clinic visit. They will be on double lumen tracheostomy at home, and these patients are the ones that we plan decannulation on an elective basis. So during the clinic visit, we're able to perform an upper airway endoscopy, and also the patient will be electively admitted for overnight observation. Sometimes even the tube can be removed in the clinic. So this depends on how prepared the patient is. But like I said, this is a medical legal era. I'm obliged to tell you that the safe practice is to admit the patient and observe overnight. But of course, there are more unwritten elements that we take into consideration, logistic factors, financial factors that may lead you to just remove the patient in the clinic itself, provided that it is safe. Okay, so I've divided it into 3 steps in decannulation. Like I said, decannulation is very much a subjective process. It depends on the confidence of the treating physician and how they plan to do it. Now, in this current era, we're not talking only about tracheostomies performed by ENT, but we do have other surgeons also doing tracheostomy. Of course, anesthesia, ICU doctors who do percutaneous tracheostomies will refer it to ENT. But any team performing tracheostomy and wish to decannulate can be done, but do it safely. So the assessment, the first thing I say is level of consciousness. Let's not talk about decannulation if the patient is not conscious. Okay, that one, we keep it clear. So try not to refer for weaning off tracheostomy if the patient's GCS is poor, not able to cough out, or not even able to obey our command. It's safer to leave the tube there. It's easier to take care of the airway that way. Okay, and then we look at breathing and oxygen requirement. That's off. Let's proceed. Swallowing assessment. Swallowing assessment does not necessarily have to be a formal assessment. It could be a bedside assessment. So patient is able to safely swallow, they can pass. But if patient is on tube feeding, that's not a contraindication, provided that we can safely exclude any sign of aspiration. Why aspiration? Patient should put tracheostomy. No reason. It's just that patients who have aspiration, it is safer for them to have a tracheostomy tube because it's easier to dispel the secretions that is aspirated. We're talking about saliva. Patient with aspiration should not be allowed to eat orally. Cough reflex and efficiency of cough. This can be assessed in the clinic. And finally, the one thing that we can offer in ENT is a upper airway flexible scope. So when we do upper airway flexible scope, we can actually look at the vocal fold below to the subglottic region, which is between the tracheostomy tube and the vocal fold, and also trachea and below. Okay, so like I said earlier, the best practice is to admit to the ward, preferably acute or subacute bed, and preferably on a weekday morning, early in the week, and definitely must be accompanied by caretaker. There's no such thing as decannulation or tracheostomy care without a family member who's able to take care of the patient. Okay, this is a repeated diagram. I think earlier talk by Dr. Pira has shown excellent anatomical and positional sense for different types of tracheostomy. So as you can see here, normally patients on tracheostomy, long-term home use, they won't have cough, okay? But I just wanted to show how in this diagram, the vocal folds are located here. The tracheostomy is located here. We have this space is actually the subglottic space and upper trachea. So this space is where potential pitfalls can happen, because right now this tracheostomy tube is bypassing this very narrow space of the airway, the vocal fold and the subglottis. So this area we have to safely exclude any pathologies by performing either an upper scope and looking down here, or we can scope through the tracheal lumen down, or even through the fenestration and look up to the vocal fold. So all this is clear. This is a picture of a bronchoscopic image through the tracheostomy tube. So you can see the tip of the tracheostomy tube, and this is the carina where the bronchus separates to right and left. Okay, so easily you can do a flexible bronchoscope using a tracheostomy tube. But the important thing here, I say, is the assessment of the vocal fold and subglottis and upper trachea. Because this part, any form of scarring can cause some stenosis here, granulation tissue. So all this needs to be excluded before we can talk about taking out this tube. Very important is the assessment. Okay, once we have seen the patient and we have decided, yes, this is a patient good candidate for decannulation, okay, like I said, advisable to admit the patient to the ward. Okay, or if the patient is not yet ready to be admitted to the ward, you feel, yeah, I want to reassess, you can do something called spigot training. Okay, spigot. Basically, it's just a occluding of the tracheostomy lumen or capping of the tracheostomy lumen. Okay, sometimes some patients, depending, maybe you're not so confident to leave them, or even the caretaker or patient is not so sure whether they are ready to take out the trachea tube, especially the secretion part. So sometimes we allow them to train at home, meaning daytime spigoting. Put the spigot in the daytime. Every time patient needs to take it off to suction and whatnot, they can document it. And then at night, do not spigot. Why? You do not want the patient to be sleeping with the tube occluded and nobody watching the patient. So we allow daytime spigoting in a condition where there's somebody else living in the house and can watch the patient. Okay, so you require a fenestrated tube like the one we showed earlier, or a smaller size tube. For example, if the patient is at home on a size 7 or size 8, Shiley is equivalent. The diameter is actually similar to a 7.5, Shiley 6. So we would downsize to a size 6, something smaller. The patient can still breathe, it's a rescue airway, but you close the tube. Okay, but more commonly is we do spigot and admit the patient for 24 hours. Okay, so I call this a 48-hour decannulation process in ward. I think the pediatric one is more, decannulation is more strict in that sense, but most hospitals we do this technique. Okay, we'll admit the patient, and the first 24 hours we will apply spigot to the patient. So the patient will be admitted in the morning. We occlude the lumen of the trachea, and then we monitor the patient daytime. Depends, 1 to 4 hourly. You can't have the, if you have a SpO2 machine in the ward that is available to monitor 24 hours, then by all means continuous. But during the daytime, we allow 1 to 4 hourly because we don't expect much problem. We watch out for the common signs of respiratory distress, stridor, dyspnea, secretions, tachypnea, all those kind of things. The nursing care will document the frequency of suction, meaning suction means we have to remove the cap. Okay, and the MO on call in the evening will come and make a decision for overnight spigot. So meaning that provided the patient can sustain throughout the daytime, during this first 24 hours, we will keep the tube occluded overnight for the overnight monitoring. So it's recommended overnight to do continuous SpO2 monitoring if it's available. So that's why we say either acute or maximum subacute ward. What we need to prepare a bedside the patient. So if you're gonna downsize the trachea tube, you have to have even smaller trachea tubes next to them because you cannot put back the old larger trachea tube if there's any problem. Emergency tracheostomy stat is needed, and also emergency trolley with well-equipped ATT and low threshold for any intervention should the patient go into distress. So the first 24 hours is a trial of occluding the tracheostomy tube. Okay, I'm doing adult tracheostomy decannulation. So this is not a pediatric patient. This is just a religious patient, came back from pilgrimage, or a monk. The hair is bald. Okay, so what happens is that trachea tube will be occluded here, and this is a downsized trachea tube. Meaning if this patient's trachea is naturally an 8 millimeter internal diameter, we put here a 6 millimeter, and there's no need to fenestrate because there's space around the tube for the patient to breathe. So this is how the patient will breathe for the first 24 hours. Alternatively, of course, you can have fenestrated tube. So it depends. Fenestrated tube, sometimes you can make your own fenestration, you can cut. Sometimes the set that the patient buys, the original one that they go home with, very famous brands, Shiley or Portex, they do come with fenestration. So these are the two options. So this is how the patient will be when it's spigoted, all right? And the voice should be excellent at this point of time. Patient will enjoy this moment very much, actually. Hopefully, that means this patient can be decannulated. And then the final step is the actual removal of the tracheostomy tube, okay? So when both the physician and the patient are confident of safe decannulation, in the second day, early in the morning, we'll take out the tracheostomy tube, we'll clean the stoma site and just cover it with a gauze. Simple, just cover with a gauze. There's no need for suturing, there's no need for taping the neck, there's no need for compression bandage, just a simple cleaning of the wound and covering with gauze. Okay, and then the second 24 hours is the same like the first 24 hours. Keep the patient close monitoring, overnight observation of any complaints and any desaturation. Okay, but please take note, the moment the tracheostomy tube comes out, the stoma will start contracting. It will close rapidly. The same tube that was in the patient before that is highly unlikely to be able to be reinserted. Okay, so bedside at this moment in time, the medical officer in the ward should know that smaller diameter tube should be ready at any time. And definitely an emergency trolley has to be nearby with multiple sizes of endotracheal tubes as well. Okay, so this is a very critical time. The second 24 hours is a very critical time. So whatever decannulation of tracheostomy tube, do it in the morning. So if anything happens, it's in the office hours, there's backup and the response time is faster. Okay, any complications of tracheostomy decannulation should be avoided at all costs. And it can be devastating, okay? All right, successful decannulation. Okay, this is a very, very happy moment for patient and doctor. So patient is allowed to return home safely after 24 hours of non-desaturation, good coughing out of secretion, good oral intake. Everybody is happy. We'll allow the patient home. We'll advise on dressing on the stoma side. Some patients, you can sort of predict what kind of wound you have after tracheostomy. Maybe next time I will share some pictures. Today I didn't manage to. So you can just send home with simple dressing, saline daily dressing. If the patient and family are confident, they can do it themselves, or we can give clinic kesihatan or even GP some additional business to help us out on this. Definitely, we need to follow up these patients. I usually give a month. There's no hard and fast rule. You can see the patient earlier if you want more patients in your clinic, or you can see later. There's not much different. As long as you discharge the patient home with advice, with a follow-up. So why we need follow-up is because we want to make sure that the wound has healed properly, okay? So this is okay, the stoma is closed, but if this is a young female lady, she won't be happy. Even males, you know, it's not a nice scar. So we can do some scar management of here, or even some injection of steroid. And this is one of the complications of decannulation, whereby the tube has been dislodged, but this patient has an opening into the trachea. We call this a tracheocutaneous fistula, okay? The trachea is communicating to the skin, there's no tube there, it's not closing. So this kind of condition will need a surgery. Okay, we can do surgery under local, even general anesthesia, but most importantly, we have to ask ourselves why didn't this close? So sometimes you put the camera in, have a look up there. Sometimes there could be some sort of suprastomal granulation or even subaortic stenosis. Remember the very critical part between the vocal fold and the stoma. So if this part here is narrow, it's natural that this hole won't close up because the patient's body wants to breathe and they've chosen this alternative pathway better. Or the more likely thing is that there has been some skin migration, squamous migration into the stoma, meaning the stoma has been lined by skin, whereby that you need to actually excise this whole skin and allow it to heal. So these kind of things can happen. Okay, if you see patients walking around with saliva coming out from trachea side after a month or beyond that, please refer it back to us. Let's give our patients good quality of life post tracheostomy. Okay, so it's pretty straightforward talk today. In our service, in our care, let's always remember there's life beyond tracheostomy. So part of our long-term planning for tracheostomy patients, especially our patients on long-term tracheostomy, is planning for decannulation, creating a timeline for decannulation, give the patient some sort of expectation. Yes, we do have patients on long-term or lifelong tracheostomies, but it has to be justified. And if there's a chance to wean off the tracheostomy, nowadays we have a lot of ways to help the patient. Should there be no contraindication, let's find a way to bring some joy into this patient's life. So we aim for early weaning when possible, but of course, only when it's safe. And I do have some studies that we have references which say that the most important predicting factors for successful decannulation is effective cough as well as tolerance to spigoting. Okay, so those are the two most important predictive factors. So even in primary care setting as well, if you would like to consider patients for decannulation to refer, these are the two things that can be considered. Okay, and please take note that decannulation process will differ between adult and pediatric. So pediatric population will be introduced to you later by our next surgeon in the evening, Ms. Iris. Okay, thank you very much for your attention, and I'll pass it over back to the chairperson.
Terima kasih diucapkan kepada Mr. Azman atas sesi perkongsian yang santai dan amat berinformatif tadi. Para peserta yang dihormati, tamatlah sudah sesi ceramah pada pagi ini untuk slot pagi. Kini kita akan rehat dari pukul sekarang sehingga ke pukul 2 petang dan slot ceramah untuk sesi petang akan bermula tepat jam 2 petang. Harap maklum. Sekian, terima kasih.
Stone unturned, no tears to damn you. When jealousy burns, cold, cold heart, how done by you. Something's looking better, baby, just passing through. And it's no sacrifice, just a simple word. It's two hearts living It's a human sign when things go wrong. Interval lingers, temptation strong. And brushes her long blonde hair, and then she asks me, do I look alright? And I said yes, you look wonderful tonight. One turns to see this beautiful lady stars in the sky don't mean nothing to you, they have a mirror. I don't wanna talk about it, how you broke my heart. If I stay just a little bit longer, if I stay, won't you listen to my heart? Oh, baby, my heart.
If I stand all alone, will the shadows hide the color of my heart? Blue for the tears, black for the night, peace the stars in the sky don't mean nothing to you, there's a mirror.
I don't wanna talk about it, how you broke my heart. If I stay just a little bit longer, if I stay, won't you listen to my heart? My heart. I don't wanna talk about it, how you broke my heart. If I stay just a little bit longer, if I stay, won't you listen to my heart? My heart. My heart. My
I could hardly believe it when I heard the news today. From a look upon your face, I see it's true. So tell me all about it. Tell me about the plan you're making. Oh, tell me once more before I go. Tell me how am I supposed to live without you? No is gone. I came to you and never asked too much, wondering what you would say, hoping you'd understand it's not a role I usually play. Don't speak too much of what's been going on. The past is over and gone. Give me your troubled mind, you know it's used. I can do so much for you. I want you having you near me, holding you near me. I want you to stay and never go away. It's alright having you near me, holding you near me. I want you tonight, it feels alright, feels alright. You're brave to say that you get lost in love, but you opened your heart to me. Underneath all you feel, you know how deep our love could be. Tonight we'll touch until it's time to go. Then I'm leaving it up to you. Even a fool will know that I'm not through. I can do so much for you. I want you having you near me, holding you near me. Yeah, I want you to stay and never go away. It's alright having you near me, holding you near me. I want you tonight, it feels so right, feels so right. I want you having you near me, the one who promised me her love. Where did it go? Does anybody ever know? How do you heal a broken heart that feels like it will never be this much again? Oh no, I just can't let go. How do you heal a broken heart that feels like it will never love this much again? Oh no, tonight I'll hold what could be right. Tomorrow I'll pretend to let you go. And were you ever what you see? Or was I a fool who fell in love with his own dream? And now you say you want to leave, start a new life today. Those words I thought you never said. How do you heal a broken heart that feels like it will never be this much again? Oh no, I just can't let go. How do you heal a broken heart that feels like it will never love this much again? Oh no, tonight I'll hold what could be right. Tomorrow I'll pretend to finally put it all behind me. Wake and find that I have found a new life in my soul, and find that I know how to let you go. You go. How do you heal a broken heart that feels like it will never be this much again? Oh, I don't know, girl. I just can't let go. How do you heal a broken heart that feels like it will never love this much again? Oh, no, no. Tonight I'll hold what could be right. Tomorrow I'll pretend to wake and put it all behind me, and find that I know how to let you go.
You ask me if I love you, and I choke on my reply. I'd rather hurt you honestly than mislead you with a lie. And who am I to judge you in what you say or do? I'm only just beginning to see the real you. And sometimes when we touch, the honesty's too much, and I have to close my eyes and hide. I wanna hold you till I die, till we both break down and cry. I wanna hold you till the fear in me subsides. Romance and all its strategy leaves me battling with my pride. But through the insecurity, some tenderness survives. I'm just another rider, still trapped within my truth, like a hesitant prize fighter, so trapped within my youth. And sometimes when we touch, the honesty's too much, and I have to close my eyes and hide. I wanna hold you till I die, till we both break down and cry. I wanna hold you till the fear in me subsides. At times I'd like to break you and drive you to your knees. At times I'd like to break through and hold you endlessly. At times I understand you, and I know how hard you try. I watch while love commands you, and I watch love pass you by. At times I think we're drifters, so searching for a friend, brother or a sister, but then the passion flares again. Sometimes when we touch, the honesty's too much, and I have to close my eyes and hide. I wanna hold you till I die, till we both break down and cry. I wanna hold you Every claim you stake, I'll be watching you. Since they're gone, I've been lost without a trace. I dream at night, I can only see your face. I look around, but it's you I can't replace. I feel so cold that I long for your embrace. I keep crying, baby, baby, oh, can't you see? You belong to me. I'm a poor heart aches with every step you take, every move you make, and every vow you break, every smile you fake, every claim you stake. I'll be watching you. Every move you make, every step you take, I'll be watching you. I'll be watching every breath you take, every move you make, every bond you break. I'll be watching every single day, every word you say, every game you play, every night you shake, every breath you take, every move you make, every bond you break. I'll be watching every single day, every word you say, every game you play, every night you stay, every breath you take, every move you make, every bond you break. I'll be watching every single day, every word you say, every game you play. I'll be watching you.
I need, baby, I need your love right now. And I want, baby, I want to show you how. Come on, you know that we've waited long enough, and now it's time to be lovers. I try to be all you want me to. And it's hard, but baby, it's worth it all for you. And it hurts making me wait for you this way. I can't go on, so come on and take me out, take my love, make come true the feelings I've been dreaming of. Take me now, take me fast. You can trust in me, our love will ever last. I know we haven't known each other long, but still something so right just can't be wrong. Besides, it ought to be up to me and you when it's time for each other. I live, yeah, for the day we live. over all the things we've done. But now, baby, I need your love right now. I can't go on. So come on and take me now. Take my love. Make come true the feelings I've been dreaming of. Take me down. Take me back. stuck on you. I've got this feeling down deep in my soul that I just can't lose. Guess I'm on my way. Needed a friend, and the way I feel now, I guess I'll be with you till the end. Guess I'm on my way. Mighty glad you stayed. I'm stuck on you, been a fool too long. I guess it's time for me to come on home. Guess I'm on my way. Whoa, so hard to see, yeah, that a woman like you could wait around for a man like me. Yeah. Guess I'm on my way. Mighty glad you stayed. Mighty glad you stayed, yeah. Oh, mighty, mighty, mighty glad. Yeah. Oh, I'm leaving on that midnight train tomorrow, and I know just where I'm going. I've packed up my troubles and I've thrown them all away. Cause this time, little darling, I'm coming home to stay. I'm stuck on you, yeah. Got this feeling down deep in my soul that I just can't lose. Guess I'm on my way. Needed a friend, and the way I feel now, I guess I'll be with you till the end. Guess I'm on my way. I'm mighty glad you stayed. Hey.
Would you know my name if I saw you in heaven? I must be strong and carry on, 'cause I know I don't belong here in heaven. Would you hold my hand if I saw you in heaven? Would you help me stand if I saw you in heaven? I'll find my way through, 'cause I know I just can't stay. heaven. Time can break your heart. Have your begging, please, begging, please. Would you know my name if I saw you in heaven? Would it be the same if I saw you in heaven? Beyond the door, there's peace, I'm sure, and I know there'll be no more tears in heaven. Yes, I know there'll be no more tears in heaven. Imagine there's no heaven. It's easy if you try. No hell below us. Above us only sky. Imagine all the people living for today. Imagine there's no countries. It isn't hard to do. Nothing to kill or die for. No religion too. Imagine all the people living life in peace. You may say I'm a dreamer. Hello, darkness, my old friend. I've come to talk with you again, because a vision softly creeping left its seeds while I was sleeping, and the vision that was planted in my brain still remains within the sound of silence. In restless dreams I walked alone. There are streets of cobblestone, beneath the halo of a street lamp. I turned my collar to the cold and down, when my eyes were stabbed by the flash of a neon light. Split the night and touch the sound
Selamat petang diucapkan kepada para peserta sekalian. So kita akan bermula dengan slot sesi petang kita untuk ceramah kita pada hari ini. So dengan ini saya ingin menjemput Miss Insyirah Muhtar, pakar perubatan ENT kita yang akan menyampaikan ceramah beliau yang bertopik Operative Aspects and Complications of Tracheostomy among Pediatrics. Dipersilakan.
Assalamualaikum warahmatullahi wabarakatuh dan selamat petang dan salam sejahtera. So saya Insyirah binti Muhtar. So now I'm going to present a topic of pediatric tracheostomy, operative aspect and complication. Okay, just a quick brief definition of tracheostomy. So tracheostomy is actually making an opening into the trachea, while the tracheostomy means converting this opening to a stoma on the skin surface. So by definition, there is a surgical opening on the skin and the anterior wall of the trachea to facilitate the breathing. And this tracheostomy can reduces the upper airway anatomical dead space up to 50%. Okay, indication of the tracheostomy in pediatric. Just now, as we had the lecture on the indication of tracheostomy in adult, so I'm going to brief about the indication in pediatric tracheostomy. It's almost the same with the adult, but there's some specific, especially on the upper airway obstruction. So in pediatric, usually it can caused by the congenital craniofacial abnormalities, such as Pierre-Robin syndrome, and also the head and neck tumors, such as cystic hygroma and hemangioma. And it can be because of the infection disorders such as epiglottitis and croup, and laryngeal trauma. Other causes is laryngeal trauma, burn, and fractures. Okay. The upper airway obstruction can be based on the anatomical site, which, for example, in the tongue base can due to microglossia, or in the nose or nasopharynx can be due to the choana atresia. Supraglottis due to the supraglottic cyst. Glottis can be secondary to vocal cord palsy, physical trauma, and subglottis can be due to stenosis in the subglottic region and hemangioma, and also in the trachea due to the higher tracheal stenosis and tracheomalacia. Okay, other than upper airway obstruction, the prolonged ventilation, such as in cases of neurological diseases and neuromuscular deficit, and also in this common in a chronic respiratory problem, such as bronchopulmonary dysplasia and tracheobronchomalacia. So the neonatal larynx is able to tolerate prolonged intubation compared to the adult because it is softer and flexible. But there is no definite consensus about the length of time. When should the tracheostomy, when is the ETT can be kept and proceed with tracheostomy. So however, in the premature babies, it may now be intubated for several weeks to months. And in older children, usually about 2 to 3 weeks post intubation. So a study by Liu et al. Reported that tracheostomy placement occurred at average of 42 days, which is about 1 month plus after admission, with the mean length of the inpatient stay being of 87 days, which is about 3 months. Okay. Other indication, this is similar to the adult pulmonary toileting, especially in neurological patient, and also patient with recurrent respiratory infection and history of aspiration. Okay, for pre-op assessment, so it is important that we have to assess the nasopharynx, the laryngeal structure internally via the flexible scope. And this is to facilitate the diagnosis to confirm the diagnosis, and also to exclude the treatable cause of obstruction. Okay, other than that, we should examine the neck. We know, as presented before, the neck is shorter in neonate, and there is more prominence of subcutaneous fat, and the larynx is higher because the hyoid bones and the thyroid cartilage usually overrides, and making the thyroid and cricoid cartilage is not easily palpable. Okay. Other than that, we should do the chest X-ray, especially we want to know how bad is the lung disease, and also to indicates the position of the trachea, whether it is situated in the midline or being shifted, and also the common blood tests, pre-operative like other surgery, and especially the football count to see the hemoglobin level, which might need cross-matching for the patient with anemia. And also we should correct the coagulopathies prior to the surgery. Okay, other than that, we should assess for the cardiostasis because it can affect the overall pre-operative area. Okay, this is most important thing is actually pre-op parental counseling. This is involved the multidisciplinary meeting, including the pediatrician, neonatologist, ENT, and also anesthetist. So we usually counsel about the reassurance, about the voice issues, the swallowing, the feeding, and the tracheostomy care, especially post-op care, home care, and also we can also share about the educational material, or we can arrange for the meeting with other parents with the children with tracheostomy. Okay, next. Okay, so this is in OT. We should prepare for basic pediatric tracheostomy set, including the blade and scalpels, blade size 11 and 15, bipolar fine dissecting scissors, R3 forceps, 2 forceps, skin retractor, suction, needle holder, and suture cutting scissors. So other than that, we should also prepare local anesthesia and non-absorbable and absorbable sutures, such as for absorbable, such as Vicryl, and non-absorbable is Prolene or silk. And okay, sorry. And we should also, prepare the connector. This is important. Connector between the tracheostomy tube and the anesthetic tubing, and also the tracheostomy tubes, appropriate size of tracheostomy tube, and also one size tube smaller and also larger. Okay, choices of tube. Mostly in children, especially in neonate, we will use the uncuffed tube. And also because in children who require long-term tracheostomy and also who are not at risk of aspiration. While the cuffed tube, usually for the older children, which require mechanical ventilation to prevent air leak and maximize the ventilation, and also who has a risk of aspiration. Okay, tracheostomy tube sizings. Belt and Watt in 2005 has found a formula to calculate the appropriate inner and outer diameters of the tracheotube based on the age and the weight as follows. So for easier ways, you can just refer on the table based on the age. Usually the tube that is cuffless is actually below 5, size 5, and tube with the cuff is above 5. Because the more larger the tube is more for the more older children. So this is the examples of the tracheostomy tube in neonate. Okay. Okay, now we move on the technique. This is the main part. The technique basically for the tracheostomy is the basic thing is actually same as the adult. However, there is some specific technique or extra technique that we should do for the pediatric because of the anatomical of the neonate, such as about the positioning for the secure and also to prevent the complication. Okay, so first in the positioning of the patient, it should be supine and with the neck extended, okay, by putting a shoulder roll behind the shoulder using either the, you can use the towel roll or can use the gel pillow. And also we have to support the neck with the head ring. It's like this lah, with the head ring. Okay. Okay, then we should put a chin strap. Chin strap, you can use a long gauze or you can use a tape which apply on the mantle area of the neonate and anchor it to the superior part of the edge of the bed. Okay, this chin strap is make the trachea closest to the skin and for the better access. So you can see because the neck of the neonate is so short, so when we extend and we apply the chin strap, so the surgical view is more prominent. Okay. Then we have to mark the anatomical structure. Okay, the anatomical structure. So first, as usual, we have to mark the hyoid bone, the thyroid notch, the cricoid, and also the suprasternal notch. And we made a planned incision site in between the cricoid and also the suprasternal notch, and like this. And then after that, we can give LA into the pretracheal area before we drape. Okay. So then we area clean and draped, then proceed with the skin incision with the blade size 15, and we will encounter a lot of fat as soon as we break through the skin. We should remove the fat, the subcutaneous fat, because it can allow you a better view of the trachea, and also this is important because to help to prevent complication. Let's say it's when there is a tube dislodgement, so it will not be obscured by this subcutaneous fat. Okay, next, the skin and also the subcutaneous tissue will be retracted and expose the strap muscle. Okay, then the strap muscle will be retracted laterally or it can be dissected. Okay, and then we need to identify the thyroid gland, especially the isthmus, and we can retract it superiorly. Okay, we retract it superiorly, or we can also divide the isthmus using the bipolar-dectomy. Okay. Then we have to identify the cricoid and also the tracheal ring, especially from tracheal ring 2nd till 5th tracheal ring, and then confirm the trachea by using the air bubble aspiration, as in this picture. Okay, how much we have to expose? So if we underexpose, it will make uncertain. We will have difficulty in securing the bleeding because there is limited space. So, and also we can ascertain the related structures surrounding the trachea. So, however, if we overexpose also is not good, because overexposure is especially inferiorly, we can cause injury to the apex of the lung and also to the brachiocephalic vein, while posteriorly we can increase risk of injury to the esophagus and also the nerve. Okay. Next, okay, this is extra compared to the adult. Okay, the placement of the bilateral stay sutures. So bilateral stay sutures is actually a sutures that we put on the either side of the between the second and the fourth tracheal ring. Okay, on the either side of the planned tracheal incision site. So we put two sutures as non-adhesible sutures, usually either like silk or poly on either side before we cut on the tracheal we cut on the trachea. Okay, these stay sutures intraoperatively it serves to assist in elevation of the trachea and facilitate exposure of the tracheotomy incision. So because when we do we're going to later I show you when we want to put the tube, we can pull up the stay suture to elevate the trachea and make the trachea more anteriorly. Okay, so while post-operatively, it can be kept for a period of time for easy replacement of the tube due to the blockage or dislodge, especially in the immediate post-op, because in the immediate post-op, the tract haven't matured, so we can have a false tract or loss of tract. So this will help to reinsert the tube. Okay. Okay, then we made a vertical incision, midline vertical incision on the trachea using the blade size 11, made across the second to fourth ring, in between the stay sutures. So actually, study shows that about the various tracheal incision by McRae et al. In 2004, and reported there's no difference result in complication or complication when comparing on the different types of tracheal incision, because some can be done in horizontal or vertical, but there is no like difference in the result of complication. Okay. Next is maturation sutures. So maturation sutures is meant to secure the tracheal wall to the skin edges to form a mature stoma. So usually we put the sutures. This is the tracheal ring. Okay, we put the sutures, especially on the inferior part is the most important, inferior part. So we hook the tracheal ring and switch it to the wall, to the switch it to the skin. Okay, so make up the wall of the trachea permanently in contact with the skin. Okay. Okay. Then after that, when we're ready, but this is okay. This maturation suture is actually sometimes it can be like optional, because like I personally also I don't like this maturation suture because it can increase the risk of tracheocutaneous fistula later on. But sometimes it's very helpful in order that if the patient in long-term tracheostomy, because it can prevent further complications such as like tube dislodge and blockage. Okay. Okay, now okay, now we are ready. When we are ready and we want to put the ETT, the tracheostomy tube, so we need to alert the anesthetist to withdraw the ETT slowly until only the tip is visible. Okay, so as the tube is withdrawn, you have to visualize properly until only the tip is visible from your tracheostomy site incision. Okay. Okay, then once it is clear, then you can insert the tracheostomy tube Okay, it's either by pulling this, like I mentioned before, by pulling these T sutures upward and laterally, so that the tracheal incision opening is become bigger, or you can assist with the artery forceps. Okay. Then once you insert the trachea tube, you can connect to the ventilator using the connector and check the ventilator stressing and also the chest rise. Okay. Then you can confirm the placement of the tube, because sometimes the tube might impinge on the carina, so you can confirm the placement with the flexible tube. Okay, with the flexible scope. So usually we want to confirm at least the tube is not impinging or is one-sided to ventilation on the right or left bronchus. Okay. Okay. Then the skin can be sutured by the Deflon. After that, we put on the keyhole dressing and apply the tracheostomy tie. And the stay sutures should be taped on the chest wall and labeled right and left. They said. And also the sign of do not remove, because this will be kept at least usually after the first change of tracheostomy. Okay, next, I'm going to talk about the complication of the tracheostomy. So the complication is more commonly in children as compared to adult by a ratio of 3 to 1. And it's more common in premature as compared to the term baby. And this is because the diameter of the airway is smaller, and so the airway may be occluded easily. And the mortality rate also, it varies about 0 to 6%. And in nearly all cases, the causes of tracheostomy-related death is because of the tube obstruction or accidental decannulation or dislodged trachea. Okay. Okay. Studies by Hospital UKM also conclude that the most complication is the accidental decannulation or dislodge, about 22%, followed by tube occlusion and also peristoma granulation tissue. Okay. Okay, these are the early complications. So it can cause pneumothorax or pneumomediastinum, surgical emphysema, bleeding, accidental decannulation or tube dislodge, and tube block. Okay, this is one of the commonest early complications. Usually about 20%, 28% of premature babies can be affected. Then it should be detected immediately post-op by doing the routine chest X-ray. Okay, because as we know, during the positioning, we might hyperextend the neck and cause and pull the apex of the pleura into the neck more further, so that can cause higher injury to the pleura and cause pneumothorax. Okay. Okay, next, surgical emphysema. Okay, it can be due to because the wound closure is too tight, okay, or the dressing is too tight. So the air may leak into the soft tissue of the neck and track down into the mediastinum. So usually we can observe the face and the neck will be swollen. Okay, and child will be in discomfort or pain and difficulty in breathing. So in this case, then we should reopen the wound. We can release the sutures to allow the air to track back out. Okay. Okay, next, bleeding. This may be due to the failure of the failure to achieve the complete hemostasis during the surgery. So usually minor bleeding can be due to granulation tissue around the tube, or then usually it can just be controlled by the cauterization. But it may persist from the wound edges and also from the major vessels or such as anterior jugular veins, and also the edges of the thyroid isthmus. Okay, so in this case, we can do a direct pressure, or we can pack with hemostatic gauze like Surgicel or Gautostat, and also sometimes might need re-exploration. Okay, next, accidental decannulation or tube dislodge. Okay, it's the common cause of the tracheostomy related death. The tube can be visibly come out through the stoma or just dislodge out of the trachea. Means it can be just dislodged totally from the skin, or it dislodged from the trachea but within the skin or within the subcutaneous tissue. Okay, so you should close observe for the respiratory rate, chest movement, air blast from the tube, and this tracheostomy dislodgement, the risk is increased by actually because of the loose tie. Okay, or it's because of the trachea tube is too short and means that maybe it's not appropriate size, and because of the fat or full neck of the neonates, and also excessive traction of tube from the ventilator tubing. This is also common because the ventilator tubing sometimes is very too tight. So when there is a movement, it causes the traction and dislodgement of the tube. Okay, how to prevent? We should go to secure ties and meticulous nursing care. Steadying the flange while connecting or disconnecting means you have to hold the flange while you want to disconnect or you want to do the suction, and also a lightweight ventilatory circuit, and also the surgical techniques like we mentioned before about the stay sutures and maturation sutures. So in the few days before the track matches, usually harder to reinsert the tube. So if this happens, so you have to call for help and call ENT. At the time being, you need to pull up the stay sutures upward and laterally, and try to reinsert the tracheostomy tube. If the reinsertion is failed, you might consider to intubate the patient. Okay, now we go to the late complication. So it can be due to infection, pressure shock, sore, granulation tissue, stropostoma collapse, tracheostenosis, tracheomalacia, speech and language development delay, and tracheoesophageal fistula. Okay, so infection, this is common. Okay, quite common. Usually at the stoma site due to the infected secretion that in contact with the skin causes the infection of the skin. And what we should do, we should observe and record the secretion color, smell and consistency, and do the stoma site dressing thoroughly. And then the stoma site should be clean and and also remove any crusting or blood residue, and also change the tapes daily, or when the dressing is wet or soiled. Okay, and then we should insert any suitable dressing behind the flange, put a keyhole, but never use the cotton wool or cut gauze dressing, as the fiber may enter the stoma. Okay, peristoma pressure shock. This is also very common. Okay, it can be at the inferior part of the stoma. Okay, that impinge on the lower neck or the chest, or it can be around the neck due to the tracheostomy ties. Okay, so prevention, you can minimize by a thin piece of duodenum patch. You can put here duodenum patch at the lower part of the tracheostomy, or the gauze pad, and also for the sore around the necktie, you can use the neck strap. Okay, the trachea strap Okay, neck strap, trachea strap, and also maybe can use the emollient. Okay, application of emollient around the trachea type. Okay. Next, granulation tissue. Okay, so the tracheostomy can act as a foreign body, so can lead to the formation of granulation tissue. And it tends to discharge and bleed, and if severe, it can lead to difficulty in the changing tubes. So, granulation tissue can be in the suprastoma area, okay, means above the stoma. Okay, this is the vocal cord, this is the granulation tissue just above the stoma, and also it can be at the peristoma area, okay. Okay, suprastoma collapse, okay. Okay, this is a view from the top below the vocal cord. Okay, this is the tube, and this is where the collapse, we call it suprastoma collapse. Okay, okay. So the causes can be due to infection, friction, or stasis of the secretion. So the usually in minor collapse, we conservative management as it will be improved after the decannulation. But it's more significant collapse, the surgical intervention might be needed. Okay. Okay, next is tracheostenosis. Usually this because of the local trauma or excessive cuff pressure. If you use the tracheostomy, the cuff tracheostomy tube. So the way to prevent is to inflate just enough air in the cuff to prevent air leak from around the tube and maintain the pressure between 15 to 25. Okay, last but not least, this is the summary of the precaution in neonatal tracheostomy. So it differs in many ways from adult tracheostomy, such as I mentioned before, the positioning, the chin strap, stay sutures, maturation sutures, and removal of the fat. Okay, that's the difference with the adult tracheostomy because it can cause a significant and greater morbidity and mortality. Okay. So, and pediatric airway, as we know, it is small, soft, and pliable. It's very flexible. So sometimes over retraction during the intra-op can lead to disorientation or lateral dissection, and this might lead to further complication, injury to the major vessels or nerve or to the lung. Okay. And also, the larynx also located higher in the neck compared to the adult. So we have to avoid hyperextension of the neck, especially we want to avoid the injury to the lung apex or pleura. Okay, then careful extension and exposure are critical for the successful procedure because children has poor pulmonary reserve, so any temporary loss of airway may lead to severe complication, including death. Okay, that's all. Thank you.
Terima kasih diucapkan kepada Miss Inshira atas sesi pengkongsian yang teliti tadi. Seterusnya, majlis akan diteruskan dengan sesi ceramah oleh Mr. Burhanuddin bin Salim, pakar perubatan ENT Hospital Putrajaya, dengan ceramah yang bertopik Hpj Tracheostomy Care. Dipersilakan.
Okay. Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and a very good afternoon. Thank you for everyone who are still with us today. So we purposely save the best for the last. So pediatric tracheostomy is something that's rarely done, very dramatic, you know, and so we save this for the afternoon. Thank you, Ms. Inshira, for the very comprehensive review on the operative aspects of pediatric tracheostomy. As you all can see and can probably get from the slides she showed, it's very scary. You know, I get goosebumps thinking about those tracheas that we did in our babies. And usually the surgeons as well hold their breath until the trachea is inserted into the baby's trachea. All right. So let's talk about tracheostomy care for pediatric patients. As mentioned by Ms. Inshira just now, the most common complication for peds trachea is dislodgement of trachea, blocked trachea, and these complications can be fatal for the baby. All right. So again, coming back to this slide, I think I showed one for adults, and just to give us some context, our topic today will be pediatric tracheostomy care, and I will be talking about immediate post-op and early tracheostomy care. I won't be talking about late or home tracheostomy care, because this is in itself is another topic by itself. So most of the time, patients immediately post-op will be nursed in ICU setting, and the early part will be in the ward. So everyone has a role to play. So our NICU staff, our general peds staff has a role to play. I think can the participants raise their hand? Can you do that? So maybe can you have a show of hands? Any staff from the pediatric department or pediatric ICU? Can you just raise your hands if you can? No one. Okay, it's okay. Probably no lah. Okay, that's fine. No worries. So I'll just continue. So this is a brief overview of pediatric tracheostomy care for the peds patient. Again, immediate and early. As you can see, the list here is a bit different from the one we shared this morning about with regards to adults. Right? There are a few different terms used, and we'll go through one by one. And again, the main reason and the main aim of this this topic is for us to be the main reason for us to do proper care is to avoid these complications. So certain complications are due to intraoperative stuff. Certain complications can't be avoided, but certain complications can be avoided. And the most important ones, tracheostomy block, tracheostomy dislodgement, all these can be avoided if we have proper trachea care. All right. Immediate post-op. So immediate means right after the trachea has been inserted until usually the first trachea change lah. Usually the first 48-72 hours is the most crucial time. The most crucial time mean what does this mean? It means that, you know, if patients receive inadequate post-op care, it can lead to complications which can a lot of time be fatal to the babies. So you can see, you know, babies have very short neck, a lot of flabby tissues, and the trachea is very small, and a lot of patients in pediatrics, as we saw just now, the indication for trachea is upper airway obstruction, you know, huge tumors and stuff, vocal cord stenosis, all these things, upper airway obstruction. So if you dislodge the trachea, it's usually the end for the patient. All right. And again, as I said, it's usually taken care in the NICU or PICU setting. Now, first of all, is the tracheostomy cut. So this is something that is mandatory for all patients, all pediatric patients post tracheostomy. So the responsibility to prepare this is usually by the ENT team, the surgeon, the team who did the tracheostomy. However, attending healthcare professionals, nurses, and doctors, pediatric MOs, those involved in the care of patients must know where to find this information. And if it's not available, you must ask from the ENT team, where is this information? All right. So this is called a tracheostomy cut. This is done by our colleagues in big specialist pediatric centers, and all of us benefit from this kind of our templates for us to use in our patients as well. So this card contains several very important information that must be handy at all times, because whatever you do, pediatric patient, it's not like a one mold fits all. So every patient is different. Every patient has a different size of trachea, different this, different that. You know, so whatever emergency things that we need to do depends on this tracheostomy card. So what does it contain? Okay, first of all, number one, the patient's ID and the tracheostomy. So the type of tracheostomy, as you can see just now from this morning, there are many types of peds tracheostomy. So what's important is the inner diameter of the tracheostomy and the distal length, if possible. Why is this important? I think you all can guess by now. Suctioning, right? And then which group does the patient belong to? Neonatal, pediatric, or adult? Is the tracheostomy cuffed or not? Usually no, as we mentioned, but it need to be mentioned clearly here. And usually there is information as to how much what size of suction used and what depth of suction needs to be done. We'll go through that in a bit. And what's more important is this patent upper airway. Is there patent upper airway? All right. Why is this important? Because the algorithm for emergency tracheostomy block differs between those with and without patent upper airway. So those without patent upper airway, as I mentioned, those with a huge neck tumors, upper airway obstructions, basically non-intubatable patients. All right. So let's look at these points. So information must be readily available at the bedside. All right. So if the ENT didn't prepare, you have to ask them, where is this tracheostomy cut for this patient? Right. All attending healthcare professionals, and this includes doctors, nurses, must know where to get this info. Not necessarily have to know, but at least you must know where to get the info from. And ideally, this should be passed over during each shift for all the attending staff. All right. So again, so let's go back to the stay suture. So stay suture, a patient will come out from OT with this on their neck. All right. So with the diagram on the right. So this is a baby who has just done tracheostomy. So you can see ventilators connected and have these two string coming out from the neck. All right. So it's important. What's most important is to make sure right is at the right side and left is at the left side. Okay. In emergency situation, the cannulation is in emergency cannulation of tube. In the first few days of or first week of the tracheostomy, it's imperative that for us to use the stay suture technique to insert the trachea back into the lumen, into the trachea. How do you do this? I think Ms. Inshira already mentioned you pull anterior and lateral. However, the caveat is, the most important syarat is that you have to make sure the right's on the right, the left's on the left. Can you imagine what happens if you pull the right, use your right hand to pull the left, the right suture and left? So you're gonna cause scissoring, and you're gonna actually close the incision, and that'll be the end for the patient. All right. So this has to be checked as well. Every scene, every shift, if possible, right and right to the right, left to the left. Okay. So this is an example of a patient that we did tracheostomy in Hpj maybe one and a half years ago. So this is the tracheostomy card that was available at the patient's bedside. Okay, all right. So similar things that we've discussed just now. Next, what's important for pediatric tracheostomy is the tracheostomy kit. All right. So this is something that's practiced all over the world. Okay, I've got this picture from the Great Ormond Street Hospital for Children. Gosh, one of the leading children's hospital in the world. So they have their own sort of guide and guideline for us to use around the world. And this is an example of a tracheostomy kit. So again, this has to be by the patient's bedside at all times. All right. The contents should be regularly inspected either by the nurse or the ENT team. So what are the contents of the tracheostomy kit? At least, so it depends on what sort of trachea tube was used. So we usually use Shiley or Portex. All right. So so must have one of the same size and one of half a size or one size smaller to be available in the tracheostomy kit at all times. Now, suction catheter, we'll talk about that, but you have to have the correct sizing inside the trachea. So in the case of emergency or blocked tracheostomy in pediatrics, there's no time to calculate ×2, -2, whatever. Right? So everything has to be done before trachea is done, so that everything is just ready for you to be used. All right. Next are our adjunct stuff like tracheostomy tapes, lubricants, and scissors. Okay. So this is the minimum bare minimum that needs to be available by the patient's bedside at all times. So what can the nurses or paramedics help? So you can always, if you have time, have a look and see if the contents are missing, or if the KY dah habis or the tape dah tak ada. Just inform the ENT team for us to replenish the supply. Okay, let's go to suctioning. Again, probably one of the most important nursing care or skill for tracheostomy patients. As I mentioned this morning, is a diagnostic as well as a therapeutic thing for the patient. All right. So in the pediatric population, there are some indications for suctioning. Essentially, everything under the sky lah. Okay. Any signs of secretions, you have to suction. Any signs of respiratory distress, suction first. Any suspicion of blocked tube or partially blocked tube, suction first. And if you can feel the child's gurgling sounds, and usually a lot of patients, pediatric patients, have neurological abnormalities, so they are unable to clear their own secretions. So that's why they were on a trachea in the first place. So this ability doesn't come back. So memang they won't be able to clear the secretions. So when you hear gurgling sound, it's time to suction the tube. Vomiting, desaturation, any changes in ventilation pressures, you probably need to suction because it might be blocked, that kind of thing. And sometimes in the older child or those with the trachea for a long time, they know when to ask for suctioning. All right, and of course before and after trachea change. All right. Again, I would like to reiterate that there's no there shouldn't be any predetermined time to check for suctioning timing. This has to be done on a PRN basis lah, when and as needed. All right. So what tube to use? Okay. So in pediatrics, there are formulas you can use. Some people use the formula of inner diameter times 2. But I think what's more important is there's usually I forgot to put it in the slide, but there's actually a chart done by our colleagues in the Great Ormond Street, which already indicates what tube, what inner diameter, what size of suction to be used. So we just use that, and it's freely available on Google, so it should be by the patient's side. Again, responsibility is usually ours when we do the trachea. But the size should be available. This is a sort of a recommended suction catheter size for according to tracheostomy sizes. All right. So for pediatrics, the depth must be predetermined before the patient. Before the tracheostomy, or rather right after tracheostomy was done lah. Okay, so that you don't have to calculate. So usually it will be written in the tracheostomy card, as I mentioned earlier, how many centimeters, 5 centimeters, 8 centimeters, and sometimes we will also ask the staff to prepare measuring tape by the bedside, so they can calculate, or they can measure the suctioning tube, how much to put it into the trachea tube. All right. Pressure remains the same, about 80 to 120 millimeter mercury. We've talked about that earlier. And durations, again, is much less than adults. Adults about 10 to 15 seconds. For peds, probably less than that. All right. So how do you do suctioning? I think if a picture tells 1,000 words, I think a video will tell 10,000 words. So let's look at this video and see if we can benefit from this.
Okay, Jude, so we do some suction. Should we clear your suction? Yeah? Yeah. Okay, should we take this off? Okay. We disconnect. Jude, hold it. Good boy. Okay. There we go. And they look okay. We pop this back on. Okay, should we do a nebulizer? Yeah, like this. Good boy. There we go. Excellent. Yay.
There you go. So you can see the child is very happy after the suction has been done. So one thing to mention about suctioning in pediatric population is that if you remember my talk this morning, for adults, we usually try to push the suction just about 0.5 centimeters beyond the tip of the trachea. For pediatrics, we usually keep it within the lumen, all right? Because we don't want to cause mucosal damage, which can be detrimental to the patient. Okay, just for your so but that usually will be predetermined before you take care of the patient. Just follow whatever the instruction that's been given. Okay. So next, let's talk about dressing and stoma care. For the pediatric patient, it starts off immediately post-op. So immediately post-op, you have to start looking at the stoma area and the dressing as well. It should be done daily, preferably more often if possible. And I think it's the same concept with the adults. When you look at the dressing, take it out, look for any signs of abnormalities such as skin redness, exudates, granulation tissue, which Mr. Ishar has mentioned, can occur quite more common in pediatric population. Swelling and offensive odor that might indicate infection. In terms of what sort of technique, again, as mentioned, in the first few, maybe the first week, it's still a surgical site. So preferably aseptic technique is recommended. Or if the tracheostomy site is infected, later at home, usually we encourage patients to use just clean methods for addressing stomach care. So again, we have some videos. I know it's afternoon, so we provided a lot of videos for you all. So these videos are available freely on YouTube, by the way.
Right, Jude, we're just going to clean your stoma. Is that okay? Yes, we're just going to take this dirty dressing away. Have a look at that stoma. And then we're going to wipe it. Chin up. That's it. Head up. That's it. Right, Jude, should we sit you up now? That's it. Oh, we're just going to check those tapes are nice and tight. Yeah. All done.
Okay. So of course, this video was done in a highly specialized center. So I think one nurse is a highly trained nurse, is able to do it alone. But in our settings, usually because of the rarity of this procedure, I would recommend at least two persons to be present. As I mentioned earlier, one to secure the trachea and one to do the procedures. All right. Okay, so coming to the next topic, the next point will be tracheostomy change. Now, the first routine tracheostomy change is usually of course done by ENT, and of course ideally it's at ICU, sometimes OT setting. However, I need to mention a caveat here that anytime immediately post-op until the first routine tracheostomy, there is still that risk of tracheostomy, accidental tracheostomy decannulation. And of course, when this happens, you have to alert the ENT on call and whatnot. However, time is of essence. Again, patients might just deteriorate and be asphyxiated without any tracheostomy. So hence the steel suture is actually useful. And I think everyone who takes care of the patient should at least be aware of, at least how to do it, because you might not be, patient, because time might take some time for the ENT person to come to bedside, all right? So, but of course, first routine tracheostomy change in the absence of any complications is done by the ENT team, all right? Later on, after the first tracheostomy change, this can be done by the bedside. In fact, it's done at home by the patient's own carer, all right? So as I mentioned, within the first week of tracheostomy, the steel suture will be there. Usually it's kept until the first tracheostomy change. So any issue, any problem with the accidental decannulation, the trachea is just changed using the steel suture. Otherwise, the first routine tracheostomy change usually is just a simple replacement, just like an in and out procedure. So this best explained again by a video.
All right, Espan, so you're going to change your tube now? There we go. Boy. Just get that bit out there. All right.
Right, you ready
Yeah,
to
if
put
we
six?
cut that side, yeah. Right.
I'm just going to clean this side. Right, I'm going to do that side.
Yeah, okay, we're doing my side now. Marie, please have the tube.
As you can see, the oh, it's not moving, is it? So during the tracheostomy, it's also a chance for you to have a look at the peristoma area, the thigh area for any pressure sores, any friction injuries and whatnot. Then the trachea thigh is taken out.
Nice and dry.
Dressing is done over the peristoma, and as you can see, there's always one person holding the trachea while the other person does the procedure. Okay. Pediatric tracheostomy very easily is dislodged. So someone really needs to hold the trachea inside too. Exposure.
Good boy. Okay, Espan. Good boy, okay, if we take this tube out. Good boy.
Okay. Notice the way to put the tube. Okay. It has to be a curved movement.
Boy.
Tomorrow on the mannequin, we'll probably see a bit clearer.
Okay, we're going to knock these tapes. I'll just tie this side. There we go. Good boy. Good boy. Should I hold this? Yeah. Good boy. And we'll turn this side. Yeah. Good boy.
As you can see, the personnel takes turn to hold the trachea, the flange, or the other does the tie on one side.
Oh, that's
Okay.
it.
Similarly, one finger.
Good boy. Boy. Cool.
There you go. And you got a happy child there with a new tracheostomy tube. Now, actually in the video, we did see how they tie the tracheostomy tie. Usually it's not the tie is not changed until the first routine tracheostomy change, because again, as you said, in the pediatric population, any sort of procedure can cause decannulation, dislodgement of the tube. So we try to avoid this unless it's very soiled and it's very dirty, and usually it's done by the ENT team within the first week. All right. But once we've done the tracheostomy change, it can be done as needed. All right. So what sort of ties do we use? What we saw in the video is a cotton tie, which is preferred in the early post-operative period. It's a bit uncomfortable for the patient. However, it's the most secure because we usually ikat mati. Okay. However, in older children or those with tracheostomy for a longer time, Velcro tie is usually more comfortable. All right. However, there is a little bit of a risk of tie to come loose because it's just a Velcro. So some kids, with a very active hand, they might pull off the Velcro and they might decannulate themselves accidentally. All right. I think this is the same thing just now. I'll just skip that. Next thing is humidification. Now, a pediatric population as well do need humidification for the tracheostomy. And this can be, as I mentioned earlier in this previous talk, can be either those with or without oxygen port. All right. So just a kid. with the HME. We did mention that earlier. So having gone through all that, I think you should prepare oneself to be faced with an emergency. All right. So those are the things that we went through. These things, that basic things that you need to be able to do in order to attend a patient with a pediatric patient with tracheostomy emergency. So these are some of the algorithms. One example of an algorithm that's used in New Zealand. There are lots of algorithms everywhere. Every center has their own. But what's important is for us to know what to do, right? So let's go through this quickly. So basically, it's the same thing with any unresponsive patient. And again, this is usually by the bedside as well. What tubes used and whatnot. But what's important is that we just look at the rate. I mean, we'll go through this tomorrow during the practical session in the suctioning station. But just a quick one. So why did I mention the first suctioning as the first skill that needs to be learned by everyone? Because it's the most important one. It's the first thing that you do anyway. All right. So appropriate suction cannot pass, means it's blocked. So what should you do? Remove blocked tube and try to change the tube to the same size. And try again. Try one size smaller. And if you cannot, use the suction tube and railroad the smaller size tube. If you cannot, you have to emergency oxygenate the patient. So this is where the issue of whether the upper airway is patent or not comes into play. So if the airway is patent, you can consider intubating the patient through the mouth. However, if the upper airway is not patent, then there's not an option. So what can you do? What you can do is you can do this. You can ventilate the patient through the stoma, either using a small face mask or an LME, right? Okay, again, I think a video will be, so this is probably the last video. So it's quite long, so just enjoy the video. We need the sound for this one.
You okay, Thomas? Can I have some help, please?
Hi, Marie.
Hiya, so just come in, he's not breathing.
You've got the
Put some
algorithm.
oxygen on.
Yeah.
Just going to suction.
So we're assessing the airway patency.
So we can't get that down.
Okay. So we haven't got a patent airway, so we need to do a tube change. You got the scissors?
Scissors.
Do you want me to cut?
Yeah, please.
Okay. Yeah.
So I'm just going to see if he's breathing.
His oxygen saturations are still falling.
He's still
doesn't-
not breathing.
Still desaturating. So should we
we'll
try and
try-
bag with the ambu bag?
Yeah. Yeah.
Okay. You got it?
Yeah, got a hold of the trachea.
Okay, so we're going to try and ventilate through the trachea. I'm not happy. That chest isn't moving.
So he's going to pop the small size in.
Okay.
So she's still not breathing.
It's really stiff. I don't get those. I think it's
Yeah,
blocked
should we
still.
try
Take
his
it out. Yeah, should we try the
upper arm?
face? Yeah. Okay. Okay, we're going to give him 5 rescue breaths. Sats are still falling. His chest isn't moving very well. Still desaturating. I'm going to take this off and we're going to use a laryngeal mask over the stoma. Okay, Marie. I'll close the mouth and try and ventilate the stoma. Okay, can you squeeze the bag?
Yeah.
Yeah, it looks like his chest's moving. His oxygen saturations are rising. Okay, so I think we're safe now.
Okay, that was a scary one, wasn't it? If I'm not mistaken, this was a real patient. If you look at the YouTube video, so I'm not sure how they did the video, but it's definitely very useful for all of us because it depicts a real life scenario for patient with the tracheostomy block. A few things that he probably you can appreciate that all the skills that we've mentioned earlier is put to good use for this kind of situation. Suctioning skills, how to open the trachea, how to take out the trachea tube, how to change the trachea tube, how to ventilate through the mouth, how to ventilate through the tracheostoma. So all these skills are very important. And in pediatrics, I think we have to be able to. I mean, everyone has to be able to do it because time is always of essence. You know, sometimes time is our worst enemy in pediatrics. There's there's no time to wait for ENT to come. So everyone has to have some sort of idea how to do it lah. So videos are all available online on YouTube freely. You know, just Google will get you this video. A few things I want to sort of see if you can see. So if you're ventilating through the mouth, be sure to occlude the stoma. And if you're ventilating through the stoma, be sure to close the mouth because otherwise air will just leak. All right. And again, you see how the importance of the tracheostomy kit bedside, the importance of the tracheostomy cut bedside, because there's no time to think. You just have to follow whatever that has been predetermined for this patient. Every patient is different. All right. Yeah, I think that's it for me today. Thank you very much.
Terima kasih diucapkan kepada Mr. Burhanuddin atas sesi perkongsian yang amat teliti tadi. Sesi seterusnya akan diteruskan dengan sesi ceramah oleh Miss Iris Chen, pakar perubatan ENT Hospital Tracheostomy juga. Tajuk ceramah beliau adalah Decannulation of Tracheostomy Tube in Pediatrics. Dipersilakan.
Can you hear?
Share.
Is it good? Okay, very good afternoon to everyone. My name is Iris and I will be the last presenter of today's workshop. And my topic is on the decannulation in pediatric tracheostomy. So in this presentation, my main focus is on how and when do we decannulate and how do we decannulate. So I believe that most of you agree that whenever it involves the pediatric population, counseling is crucial. So what are the most common questions asked by the consent giver and caretaker regarding tracheostomy? So the common question that the parents will usually ask is, when is the tracheostomy? Is it okay? Okay. So yeah, sorry. So the common first question that you will be asked from the parents during consent taking is usually, when can we remove the tube, and is the tube permanent for life? So to be able to answer this, I believe that ENT clinicians or doctors must know how and when to decannulate a tracheostomy tube. So just a short definition, decannulation also we also call it as weaning off. So it is removal of tracheostomy tube once the indication is no longer indicated. So in this presentation, I'll cover the checklist of decannulation, the decision making by the ENT clinician, pediatric protocol of decannulation, and is there any role of endoscopy, and whether there's any sequelae or complications of decannulation. So first and foremost is the decannulation checklist, one of the most important. I think Mr. Azman has already explained this on the checklist regarding adult decannulation. It is more or less the same. So the most important is resolution of the condition which necessitates tracheostomy. So it follows by successful prolonged spontaneous breathing, the level of consciousness of the patient, characteristic of a secretion, and the need of suctioning, and also whether patient has an effective swallowing and coughing, and whether the airway is patent, and whether the oxygenation is adequate. So this slide is just a summary of the indication of pediatric tracheostomy that has been explained by Ms. Inshira just now. So basically it's either a temporary indication or a permanent indication. It can be due to inflammation following burn injury or allergy reaction, can be due to acute infection causing upper airway obstruction, facial trauma to bypass upper airways, especially in patients with respiratory, muscle, and lung problems, and foreign body in the airway. Whereas in permanent tracheostomy usually is indicated in cases where the child suffers from tracheobronchomalacia, trauma following spinal injury, and also a child who needs long-term ventilation, such as degenerative or neuromuscular disease. So the relative indications can be in children with syndromic with craniofacial anomalies, in severe laryngomalacia, subglottic tracheal stenosis, bilateral vocal fold paralysis, any sleep disorder, or neuromuscular degenerative diseases or tumors like cystic fibromas. So come to the decision making of the decannulation, it is mainly depend on the indication of the tracheostomy was first performed. So either it is due to an acute issue or it is due to a prolonged chronic ventilation. And it also depends on the comorbidity of the patient, such as cardiopulmonary failure, neurological status, and etc. So in cases where the indication of a tracheostomy is due to an acute upper airway obstruction or due to an adjunct treatment, usually the tracheostomy can be decannulated directly or immediately upon resolution of disease, completion of surgery, and completion of treatment. Whereas in cases where the tracheostomy was performed due to prolonged mechanical ventilation, usually we advocate spigoting or capping trial and even downsizing the tracheostomy. So pediatrics decannulation is slightly different from the adult decannulation because pediatric, we have some protocol published online, and there are many journals has been published online regarding pediatric decannulation, and all of them has a similarities is that they advocates that endoscopic airway evaluation in the operation room prior to decannulation is important. So in 1997, Weddell et al. Published the Great Ormond Street protocol for ward decannulation of children with tracheostomy. And this protocol is widely used in our country up to date. So in the next slide, I will explain on this Great Ormond Street protocol, which is also called as a GOSH protocol. And this protocol suggested a 5 days inpatient in-ward decannulation process, in which in day 1, the child will be admitted to the ward and we will take the child to the OR for an endoscopic evaluation. So if the child has a normal airway study, we may downsize the tracheostomy tube to size 3. So in smaller babies and those with weight of less than 12 kg, we may downsize it to 2.5. So this is aimed to create larger space around the tube for child to breathe once the tube is kept. Okay, and we keep the child in acute bed in a ward with active observation. So if day one, there's no issue, the child able to tolerate the tracheostomy size 3 or 2.5. So at day 2, we will start spigoting the tracheostomy tube for 12 hours. If through the 12 hours, there is no issue, it is successful, then we proceed to spigot for 24 hours overnight. So we continue to monitor the respiratory rate and SpO2. If there is a repetitive removal of cape, it is classed as a fail. Therefore, we always encourage the child to cough around the tube rather than opening the cape and to do suctioning. And at day 2, we may allow the child to walk around the ward and hospital. So if the child passed day 2 of 24 hours of spigoting, at day 3, we may decannulate the patient. So once we decannulate the patient, we occlude the stoma with an airtight dressing for 24 hours, and this forces the air up through the nose and mouth. And at the same time, we encourage the child to continue to cough to clear its own secretion. And we continue to monitor the respiratory rate and the SpO2. So at day 4, if there is no concern, we remove the dressing, we check the stoma, we clean the area, and we replace the airtight dressing for another 24 hours. So during this day, we should revise the BLS with the parents. Okay, so we continue the respiratory rate monitoring and also SpO2 monitoring. And at day 5, if there's no concern, we remove the dressing, we check the stoma, we clean the area, and then we may replace the stoma with a simple dressing and we allow the child home with a TCA to the clinic. So what are the things that we monitor post-decannulation and what do we observe? Bear in mind that in pediatric population, they do not usually complain. Therefore, observing and record any signs of increased respiratory efforts is very important. So we can look at the skin color changes, whether the child is irritable, anxious, any increase of breathing, restless upon sleep. In younger children may have nasal flaring, tracheal tug, recession, and any presence of noisy breathing such as stridor, stator, and other objective parameters would include SpO2 monitoring, respiratory rate, and etc. So other than the protocol that I've just mentioned, there's another protocol that has been frequently used, which is produced by the Cincinnati Children's Hospital, in which they also advocate an endoscopic evaluation of the airway and proceed with keeping and spigot for 4 to 6 weeks at home. So what's the difference between these two protocols is that in Cincinnati's protocol, after the normal evaluation of the airway study, they allow the child home for keeping or spigoting the trachea for a period of time, let's say about 4 to 6 weeks at home. So if the child passes the keeping at home, either we downsize or keep the child in the ward for 24 to 48 hours. If it's okay, we decannulate. But if the child fails the keeping, we have to repeat the endoscopic evaluation. So in this picture, you can see that these 3 little cute kids, they're actually the trio of the east coast of Sabah. 3 of them were tracheostomized when they were an infant. And the 3 of them has successfully decannulated last year. And the boy on the right, his name is Arif. He was taken to the OR last year for an airway study prior to decannulation. And you can see that the videos on the right shows that the child has a normal airway study, a normal vocal fold, there's no subglottic stenosis, there's no tracheal stenosis, and it's clear up to carina, and there's no evidence of tracheobronchomalacia. Okay, so the same child, we followed the Gosh protocol. After a normal airway study, we downsized the tracheostomy tube to size 3, and the child is being observed in the ward. And at day 2, we spigot the child for 12 hours and he was well. And then we continued to spigot overnight for 24 hours. So the child was decannulated at day 3. We continued to observe and discharge the child home at day 4 and day 5. So this is just a picture to show that how cute he was when he was 8 months old and when he was decannulated at 5 years old. So other than the two pediatric protocols that I've mentioned, there are many more protocols published online, and some advocate performing a polysomnography on every child prior to decannulation. And the latest paper in February 2021, it was published in the International Journal of Pediatric ORL by a group of pediatric otolaryngologists. They mentioned that the readiness of the decannulation is based on the normal endoscopic finding, patient oxygenation requirement, and secretion management. And they advocate that a normal airway study is essential, and keeping trial is always being performed prior to decannulation. And after decannulation, the patient will be observed in the ward for at least 48 hours. So we spoke about a few protocols, but bear in mind that not all patients are suitable for weaning protocols, and there are factors that causing failure of decannulation, such as respiratory muscle weakness, slow recovery from chronic illness, anxiety from prolonged ventilator dependence, cardiac dysfunction. Therefore, some of the patients necessitates gradual weaning. So you will usually find that the parents are very emotional through the 5 days of decannulation. They are usually very excited during the process of decannulation, but at the same time, they are very scared and worried. So they will ask whether my child can go back to school, whether my child can swim, and what if not. So usually we advise that the child may go back to school and may perform normal activities right after the decannulation. However, we should advise the child to avoid swimming or any water contact until the stoma fully recovered. And if the child catches cold and cough, they should send the child to the nearest healthcare center. And if child is in distress, they should head to the emergency department. And parents must also be well versed on BLS. And usually we advise the parents do not insert back the tracheostomy tube if the child is in distress. So stoma opening will usually be there for a few months, sometimes up to 6 to 12 months in pediatric population. So what is the sequelae of decannulation? So it's either patient completely recover, decannulation failure, and tracheocutaneous fistula. So what are the causes of decannulation failure? So there are a few factors: persistent condition in which the tracheostomy was performed, whether there's any obstructive granuloma, subglottic tracheal edema or stenosis, tracheomalacia, psychological or physiological dependence. Therefore, the decannulation checklist is important. So just spare a few minutes that I'll talk about on tracheocutaneous fistula. So what is tracheocutaneous fistula? It is a pathological complication of temporary tracheostomy that results from failure of spontaneous tracheostoma closure post-decannulation. So patients with TCF, it impairs their quality of life, it affects their vocalization, it causes social stigmata, and it affects the local hygiene. And has been reported that it may be due to or related to cannulation time. And some even reported that the incidences of TCF can be up to 70% when the tracheostomy maintained more than 16 weeks. But it can also be caused, can be due to patients' comorbidities and risk factors of wound healing that impedes the healing of the tracheostoma, causing a tracheocutaneous fistula. So this slide is just to show a few examples of the TCF. And what is the management of TCF? Surgical closure. Surgical closure is the mainstay of treatment. However, patient counseling is very important because it has been reported that it has a high incidence of rate of recurrence, and it can cause complications such as pneumothorax, subcutaneous emphysema, and airway stenosis. So in cases with persistent TCF, when do we close it and how do we close it? So in pediatric TCF, it was reported that the surgical repair should be undertaken after 6 to 12 months of the decannulation. In my limited experience, I think most of the pediatric tracheostomy heals spontaneously without the need of surgical closure. However, there are few cases that have persistent TCF mainly due to poor care of the stoma, causing recurrent infection and granulation tissue that may impede the closure of the tracheostoma. So the decision of TCF, surgical closure, mainly depend on factors. Most importantly is that the parents and the patients understood the risk and complication of closure. The technique varies from primary closure, local flap technique, or reinforcement technique. And most importantly, we do not suture the tracheal ring as it may cause tracheal stenosis. With this, I thank you everyone for your attention.
Terima kasih diucapkan kepada Miss Iris atas sesi perkongsian tadi. Para peserta yang dihormati sekalian, kini kita akan berehat 5 minit dan kita akan sambung balik dengan sesi Q&A. Para peserta sekalian, kini kita akan bersambung dengan sesi Q&A. Panel kita adalah Mr. Lim, pakar ENT dan juga Mr. Burhan, pakar ENT. They will try their best to answer the questions that you all have mentioned stated in the chat box earlier.
Okay, some of the questions that we have here. The first one is, kenapa radiotherapy perlukan tracheostomy? Okay, usually these kind of cases, you're talking about head and neck cases. And a lot of times, the tracheostomy is also actually requested by the oncologist. So radiotherapy on its own, sometimes as a side effect, we're worried about any supraglottic edema, pulmonary edema. So this can lead to compromised airway while the patient is undergoing radiotherapy. So because of that, sometimes we do a tracheostomy just to protect the airway. And let's say once therapy has finished, patient is stable or the cancer is in remission. And if patient has no complications, then we can decannulate the tracheostomy later. So that's a very simple answer. Okay, the next one is, does aspirin given to PITS patient? Not really sure what the question means, but usually patients who are already on aspirin, if possible, we try to stop the aspirin before we do the tracheostomy. But again, it's a very case-to-case basis also, depending what the aspirin is given for in that kind of patients needing the tracheostomy. Because in any event that you can't stop the aspirin and you need the tracheostomy, you still have to go ahead with the surgery. So just that maybe the risk of bleeding might be a bit higher. So just need to be more careful while during the tracheostomy. And is the marking done prior or based on the CT scan? Okay, again, it depends on what the case is. But generally for all tracheostomy, like I said, you need to position the patient. And once you position the patient properly, then you need to identify your anatomical landmarks. And then from there, you can mark where you are going to make your incision in the neck and all that. CT scan is really depending. Let's say patients with thyroid CAs or any neck swellings in front. The CT scans will help you to determine where the trachea is and where you expect the trachea to be when you're doing your tracheostomy. So, but again, the marking is usually done surface anatomy. So you need to know your landmarks before you do your marking.
Okay. Right, so next question we have is okay, there was a question from our pediatric colleague. Thank you very much for the question. So the question goes as follows. In worst case scenario where patient is unable to saturate despite an LMA over the tracheostomy side, should we proceed intubation with EPT provided that the upper airway is patent? All right. So there's a few things that we need to first address. As you mentioned that upper airway is patent, so patient is intubatable. So if it has not been attempted, you should do mask back through the mouth and what including the tracheostomy side as well before that. And if unable to saturate, yes, you should proceed with intubation and bring the patient to OT immediately, because next is we need to surgically reinsert the tracheostomy tube. All right. Number 4, how long after the operation the tag will be kept? So I'm assuming this refers to the stay sutures that we mentioned earlier in the slides. I think I did mention it that usually is, the practice differs, but at least until the first change of tracheostomy. So that's when we are quite certain the tracheostoma tract is fully matured. Some students keep until 2 weeks post tracheostomy. In patients whom we deem to be, a difficult tracheostomy, short laminate and whatnot. one thing to bear in mind when we think about how long to keep is that the longer you keep, the disease, the longer you keep the cyst suture, instead of becoming a cyst suture, it becomes a nidus of infection. It becomes a foreign body. So you get problems, other problems such as like aroma, infection starts to creep in. So this has to be discussed and properly before decision. All right. Okay. Any more questions in the chat or YouTube live chat? Thank you.
Dear participants, upon discussion with our committee, we have come to consensus and agreed to provide e-certificate to participants who have gone through the journey for today's course through YouTube link as well. And the displayed link is the attendance link for day 1 of our tracheostomy course. And this QR code will only be displayed for 3 minutes. And kindly we hope that all the participants who have actually registered under us to scan the QR code. Thank you. Dear participants, are you all able to scan the attendance for today using this QR code?
Tak dapat. Kita orang buka, dia keluar dekat YouTube.
Okay. Try again. This new code kan. Hey guys, can you guys like try again with this new QR code that we display over here? Try using the new QR code that we display. I think now it's available for the attendance link. Thank you.